procedures with the unilateral biportal endoscopy. Please, Dr. Dian.
Good morning, ladies and gentlemen. Is that okay with the
Can you start with this? Okay. Change display method. This might be here.
Okay, thank you very much. It is a great honor to have presentation here today, Tashkent. I'm Hisuk Yang from Korea. The topic today is the endoscopic procedures with unilateral biportal endoscopy. Let's talk about the difference compared with the PSLD and look at some cases. Before presentation, I want to ask you why we do endoscopic spine surgery. If you ask me, I think endoscopic spine maintain healthy spine and make the better long-term result. Images below, those are drawn by artificial intelligence when they given the keyword healthy spine and the better long-term result. This is surgical scene with unilateral biportal endoscopy. The first part is that endoscope and instrument move independently and separately with an additional portals. Therefore, there is the concept of triangulation. We need instrument and scope work together. At first, it is not easy, but soon you can get accustomed to using together with triangulation. To give you a tip, the surgical field should always under endoscopic view. It may cause neural damage out of sight. We can move lenses regardless of instrument. Therefore, we can see the area when you want to see more freely. And also it helps to decompress contralateral area and to check existing nerve root with contralateral approach. The another different thing is most conventional instruments are available. Particularly, various scissors or osteotomes can be used. It is very helpful to decompress the foraminal area accompanied by severe osteophyte or doing fusion surgery. This is UVE operation setting. It is very similar with PSLD because it is the same medium surgery, fluid medium surgery, and it is safe to use the cannula to maintain fluid outflow. Let's see some cases. This is severe ruptured about migrated herniated disc. We can also remove the whole ruptured disc at once because the working portal is of sufficient size. And We can also get help from assist, such as root retraction with retractor, with additional working portal. This is foraminal disc case. Some of parts were removed with paraspinal approach, and exiting nerve root can be found. And with some retraction with the retractor, we can find foraminal disc and remove it. And also, we can check operative field and post-op MRI for sufficient decompression. Next case is foraminal stenosis accompanied by lateral recess stenosis. With a similar way, we can remove some parts with paraspinal approach and check exiting nerve root also. With additional ventral pachytectomy, we can check traversing nerve root and is it sufficiently decompressed with operative field and post-op MRI. The superior articular process can be safely removed with osteotomes. It is very useful. ULBD maybe it seemed become basic procedures in treatment of stenosis. With ipsilateral laminectomy, contralateral laminoplasty, ligament flavum can be removed and sufficient decompression is achieved. We can check with this movable lens for each side. During operation, we can also use 30-degree scope. It gives us more wide view, and it also helps with contralateral decompression with various angle scope. Fusion case, with scope portal and working portal, they are used as portals for screw insertion later. We do laminectomy and perform pachytectomy with scissors. It is very useful, and after performing pachytectomy, we can also have to do ligament flavum removal. Also, we can use very conventional other instrument via working portal, and with a different portal, we can use some more free movement. After doing anealotomy and processing limbing, and also we can see into the end plate preparation area more freely and have a good preparation, and then cage can be inserted. Strong bone bridge can occur only when enough harvest bone enter into fusion bed. Funnel-shaped cannula pierce harvest bone into disc space effectively. In some indication, we need large cage should be inserted. With UV procedure, we can insert larger cage like this. With thoracic OLF removal surgery, it is very important to do safe surgery and reduce complications. Surgical procedures are laminar shelling, decompression technique, and envelope resection technique with endoscopic surgery. The complications that are hard to avoid are CSF leakage, dural tear, and cord damage. But with endoscopic procedure, it gives us clear surgical view, and scope camera can move effectively, efficiently to 4 corners of OLF, and we can check adhesion site between the OLF and dural ossification. For cervical case also, we can remove foraminal disc after posterior cervical foraminotomy. In some situation, V-point is not consistent, depend on position. We can check V-point after tilting rotator muscle at lower border of upper lamina. If we plan the inner V-point where is mid SAP and IAP, if we plan well, we can have sufficient and proper decompression during surgery after checking the inner V-point and the drilling lateral caudal direction. Complications. Commonly, there are hematoma and dural tear. Because of we can use conventional instrument, we can try direct dural suture or using clip. Today, I briefly introduced the UB procedure, and thank you for listening.
Thank you. Thank you, Dr. Yang. I think we have enough time for question and answer, maybe today, huh? Because if anybody has some questions, you can ask. Savol auditoriyadan mabodo savol bo'lsa bemalol so'ranglar, chunki bugun yetarli vaqtimiz bor savol javobga. Yeah, I think no questions. Yeah, thank you. So next presenter is Dr. Ditapong from Thailand. He will be speaking about topic spine hospital management. So Dr. Ditapong, please. Thank you.
Yes. Thank you very much. It's honor for me to speaking here also, and also it's a click. Okay. And also this is the first time for me in Uzbekistan. But let me introduce myself first. Actually, I am neurosurgeon, but I also owner of the spine specialist hospital. I graduate MBA, major in finance and marketing and international business. And also I am a manager of a private equity fund of my international private equity fund. So many doctors in here like to be an expert about the endoscopic surgery, but some doctors like to jump to open the hospital. That is sound good. Like me, also owner of the hospital, the initial investment is for me in the hospital is roughly around 30 million US dollar. It may be more expensive in other countries, but in our country it look expensive because by law. But in some hospital, in some country, maybe regulation is less. Maybe initial investment cost is lower than this. But now investment cost is roughly about 120 million US dollar for the new hospital. So it look good, but behind the scene it's quite difficult. So before you jumping to be your own hospital, let's think about this before. So I like to talk with this before you jumping to the hospital. So this one is my hospital. If you'd like to see in the video, sorry, let's use this one, it's easier. This is my hospital. But first of all, you have to make a checklist of this one. What is the aim of your life? Because if you become an owner of the hospital, maybe you got a huge investment and good return, but it not get along with aim of your life. Because some people, they like to have an aim of your life is a peaceful life, and in the evening they go to see the children and family or something like that. But if you become the owner of the hospital, forget about it. You have to make your own responsibility 100%, 24 hours, 7 days a week. So it doesn't make your life better, but make you richer. Maybe, if you success. And another one is, when you open your own hospital, you expect it growing up. If you do the operation by yourself, you can control the quality of, and you can control the result and you can control the service. But the thing is, if you do it alone, your hospital will not grow up. So you have to hire someone do something for you. But how you control the quality? This one you have to think first, because other people do it. It's not like you do it by yourself. You are expert. You're concerned because this is your business. But when you hire someone, they're not concerned. That's not their business. It's just only the job. So think about this first. And another thing is how to finance the project. This one also very important, because many doctors they jump from the expertise to be a management. It had a different skill set, totally different. So because the hospital is basically in high investment cost, as my country, initial investment for me is $30 million US. So how to finance it? Because it's not initial for the initial investment. If your hospital is not running well, maybe you lost more money. And think about this one, maybe make your life more suffer about this one. But if you succeed, it's good. And you have to control many things. So in the hospital, basically, we control 3 major parts. One is front office. That means it's like a nurse, pharmacologist. This part is just to see the patient and make the patient happy and do the operation, like operating room or something like that. Another one is back office, like finance department, accounting, many things that not see the patient, but is something behind. And the most important is control the doctor team. How you control the doctor to get a good quality, and they not left you and do the hospital or do the operation in other hospital. This one is different skill set from what we discussed before. Because before we discussed is about expertise in endoscopic. But when you open the hospital, you use another skill set. It to be management skill set. So why I have to study in MBA? Because it's problem for me that I don't have skill set for the management. But I not ask you to study MBA, everybody to open the hospital. But think about this before. Because it's a huge investment. If you go in there, you cannot go back. So if before you investing in something, think about this one first. And another thing is, in some country, you are pioneer in that country. This one, many endoscopic surgeons face of this one, because more than when I start in my hospital, almost no doctor do endoscopic surgery. They do conventional surgery, and they always say, "Oh, endoscopic is lousy." And at that time, I have to be calm and quiet because we know the result. Everybody in here, they know the result is very good. But another doctor, they cannot do it. And they just say it's not good. But you have to be patient a lot until you success. And how to face with them, how to cope with them, how to cooperate with them. I think in some countries not happen, but some countries happen. Mm-hmm. And the last one, I like to talk about the efficiency and effectiveness. Because sometimes when you invest and open the hospital, basically, I encourage you to think about efficiency first, not think about the effectiveness. Because if you got the result first and you can trim to get the effectiveness, get it open first, and then when you're running for 3 months, 6 months, you will know which one should cut off, which one should be remain, or which one should be improved. If you think about do the best thing first, you never it never happened. Basically, if you think, oh, I have to do this, I have to get this one before I open the hospital, it never happened. Or maybe it happened when you're 55, 60 years old, and you cannot get it long. And you have to prepare for long term. It's not like you are employee now. Because when you are employee, you can quit. Tomorrow I quit. Lay down, playing with my family and something like that. But when you invest, even you sleep, the money run out or run in. It depends on situation of your hospital. It's like a marathon. So think it first before invest. And the last one, nothing lasts forever. Even myself, even yourself, nothing lasts forever. Think about how to exit the hospital. Because you invest, the hospital is your own. How make you exit? If you got a good exit, it gives you a lot of money. Either by selling the hospital out, merger with the private equity, or going with the IPO to the stock market. This one is not easy. You think in the long term. Maybe you need to prepare 5 or 7 years beforehand. So that's it. This is just only 10 minutes. I like to make a checklist before you open the hospital. But open the hospital, it's not scary. But you have to make a checklist of this one first. First, it get along with your life or not is the most important. Because if you're not happy with the hospital, maybe you not enjoy every day. But if you like it, you will enjoy every day. It's not like your job. It's like a game. And may the force be with you. Thank you.
Thank you, Dr. Ditapong. We was planning with the Dr. Yakubov to open our own hospital, but after your presentation, I think I will change my mind and I will not open. So it's not a good idea. So our next presenter is Dr. Piotr Winkler from Poland. Dr. Winkler, please. The title of presentation is Full Endoscopic Decompression in Lateral and Central Canal Stenosis.
One moment. I want to say about basics today. Yeah, that's have 15 years experience with endoscopic spine surgery. I start with Thomas Hugland. My first case in Poland was the first discectomy, endoscopic discectomy with Thomas Hugland. And it was great experience. We started in 2008. Previously, I take care about hydrocephalus, endoscopic hydrocephalus, and pituitary surgery, that I have some experience with endoscopic. But when I met him, I understand that this is the way. When I heard this previous presentation about what's with my life, I have the same questions in this time. What I will do, how I will with my family, how long I will work in public hospital. That's especially in this time, we have much more difficult situation than now in public hospitals. We were like workers. Yeah? Now I work in small private hospital 7 years, and I do in this private hospital much more cases and with much better equipment they did ever in public. I want to say today about basics, because I think it's worthy to come back to basics like I seen this. In stenosis we have two completely different fields. There's foraminal stenosis. I heard a lot yesterday about foraminal stenosis. I think it's better. My colleagues know this better. I have much more patients with central and lateral stenosis. That's, for me, it's much better to use interlaminar approach. Maybe it's a difference of aging. I have really old population, old and older. Yeah? Every year we see that in Poland we have the problem with older people, fat, large, older people. I don't see here anyone who looks like more of my patients. Yeah? You look much better than 200 kilos patients, sometimes 250. Yeah, it's really large people. And this is the reason that I use interlaminar much more than other. Yeah. This slide is now gold standard in Poland, in my country. It's still gold standard. All patients with stenosis is treated like this, and even 5 years ago, if I do endoscopic surgery, and my patients go to different surgeons, they say, no, it's a mistake. You should have something like this. Now it's slowly changing because my patients start to ask about endoscopic. All patients start to ask about endoscopic. The social media, patients speak each other and speak about completely different outcome. In Poland, we can say now that we have success with endoscopic surgery, not because the doctors understand what is it. No, because patients understand that the treatment with endoscopic is better for them. I use the valve equipment. Even I started with Maxmore because I had this large patients. Yeah? This is for me. This is more. This is much better. Yeah? I want to show you basic procedure. On this film is wow. I have to find this. We clear here. Oh. We clear ligamentum flavum, and looking for this place, the top of the descendant facet. Sorry. Oh. Okay. Yeah. Here we are. When I speak with my colleagues who start endoscopic transforaminal decompressions, they have the more problems with finding this point. Especially older people, it's not so easy like here. Yeah? When I speak for them, it's the most time-consuming it's maybe more than drilling process, because they couldn't find this point. The next, one moment. Where we find this point, everything is much easier. We start drilling, removing medial part of descendant facet here. And when we're removing medial part of descendant facet, we start to drill cranial lamina. I always want to see the end of the flavum. I know this is not necessary, but for me it's easier to removing the flavum when I see the end of the flavum. It's like here. Yeah. Here, you see here is the end of the flavum. I see the hole and give dissector and push the flavum caudal. I nearly always use this drill. It's a sharp drill. I know that my colleagues like diamond drill. It seems more safe, but it's completely not necessary. We have large barrier flavum that we can use sharp drill and do this faster. Yeah? Here is the part when we drill ascendant facet here. And then when we after drilling, we're removing this with diamonds or with cavison. This part of surgery takes about 20 minutes. That's a half of our surgery. It's drilling facets. You see we have quite large hole here, and start to removing ligamentum flavum. I did like this previously. Now I removing the flavum in few pieces. It's much faster. We have full one side decompression. Here is cavisons. And I nearly always do both sides. Because I work in a private hospital and the patient expected that they have done both sides and don't come back after 1 year. Then, like here, sorry, it doesn't work. Here is after surgery, CT after surgery. We have two sides full decompression. And this is last photo. And this is the same finger, but the patient from other hospitals. Here is extraforaminal. I don't want to show this because all yesterday we see this. Yeah? Thank you very much. If you have questions, I think we have time.
Questions. Anybody have questions from audience? Savalle var mı Dr. Piotr'ga? Questions. I have one question.
Thank you.
I have one question. How do you finish the surgery? I mean, the end point of the surgery. Which anatomical landmarks you pay attention when you do the decompression, bilateral decompression? From which point to which point you do the full decompression? At the end point of the surgery.
All the flavum. I don't have to thinking about points because I try to remove all the flavum to have wide decompressions. I start before that. I do this to the end of the tip to the ascendant facet before, but now I'm removing all the flavum. It's a little more bleeding from cranial lamina, but when I use different coagulation systems, I deal with it. It's not the problem. Yeah? I do quite large hole.
Okay, thank you. My next question is about the bleeding control. Do you use the hypotension of the patient, or how do you control the bleeding? Just the pump with the pressure?
Just pump, and I can say that the bleeding is not the problem. Last 5 years, we don't have situation that's with the problem was any bleeding. Any bleeding problems. That's we use 2 coagulation systems. One is valve system, other is bones, and both of them it's healthy. It's okay.
Okay, thank you. Thank you very much.
So you used a tubular punch here, right? The punch.
Yeah.
Yeah. So how long it lasts? How many cases approximately?
I did about 1,000 cases.
With one. With
Punch?
Yeah.
Oh, I don't count it with punch.
Okay.
One punch?
Means the instrument.
Yeah.
How long you use how many times you can use? How can you say
Idea
The question is like you are using tubular shaft punch in the surgery. That's by your spine. That instrument which cuts the bone. That's known as the tubular shaft punch. So how long does it last? Is it 30 or what?
It's okay, sir.
It's okay.
Sure that
It's
I
okay.
understand.
It's okay. It's okay. I'll talk to you later.
Thank you. Thank you, Dr. Winkler. Okay, our next presenter is Dr. Siddharth Verma from India. So he will be presenting the PSLD instruments, anesthesia. Is this one?
Yeah.
Yeah. The PSLD, the instrument, anesthesia, and OT setup.
No, I need this one. Yeah, so thank you. So this talk was a very basic talk which was supposed to happen yesterday. So this is about the instruments, anesthesia and OT setups, and will be especially important for those of you who are beginning to do this procedure, because I have recently started doing this, so I think I can share my experience. So before I begin, there's no disclaimer. I have not been associated with any particular company, but I will use some instruments which I have brought myself. So when the initial papers were mentioned, the stethoscope was mentioned in the paper by Dr. Lim, which was having 8.4 millimeter outer diameter, 5.7 working channel, 120 working length, and 12 degree optical lens scope. And now many different systems are available, and more or less they are similar with the slight variations, but as a rule of thumb they are wider to allow for bigger instruments, so that the procedure time is reduced. So I own the 4.1 system as well, interlaminar, and I can not imagine how longer it will take with this to do. Like for example, in the previous talk we were talking about 20 minutes to reach the point where with the stethoscope we are discussing finishing the procedure in 20 minutes. So that's a big difference which can be there with your systems. So understanding and choosing the system is very, very important. The drill system is another thing which is often overlooked, and we focus as a beginner more on the scope and less on the drill. And although most of the things are most of the procedure you will be doing with the punches, but to get a hold of the punch so that the bone gets engaged, and especially as a beginner it's more difficult. It's important to have a good drill system. Of course you need to have a hook to break the adhesions and prevent the tears, because it will take you quite some time to master the technique which Dr. Akror showed yesterday. So we have many equipments which now come in different shapes and form. This one particular one is the Maxmore one, which probably I brought, and you can see that it consists of, there are very few instruments which are required for this procedure, especially if you are upgrading from, or rather shifting from transforaminal to PSLD, and you actually need just a punch or a set of punches. Then you need the dilator, the sleeve, the scope, a forceps, and maybe the hook or the dissector. That's it. That's about it. So these are going to be the most important things which you choose to start with. Rather than compromising with your scope and saving some money initially, I chose to invest on my scope and get a better view so that I can have a clearer understanding of the anatomy, and I will recommend the same probably to all of you as well. So so going on to the other equipment, we have the drill. Lots and lots of drills are available. So initially probably the mistake which I made was I chose a drill which was not very up to the mark, and I tried to think that I'll do some initial cases and then I buy the new drill. I'm working in a private setup, so cost was important to me, and I suppose you will have the same issue, but investing in a good drill which now I am buying will also mitigate many of the complications, and of course it will increase your speed to a great extent, and you cannot underestimate the power of doing the procedure with speed. It builds confidence, sets up the pace for the procedure, and also helps you out with reaching the different endpoints. So going on to the RF, my previous speaker spoke about the Bonds RF, and I'm very impressed with this system, I must say, because having the privilege to use the different types of RF, I'm using and doing the transforaminal procedures for last 5 years now, and I can definitely say that this is a good investment which you can make. Again, I have not been paid by Bonds to recommend their product, but definitely it's one of the systems which you should consider at their price point. Often overlooked is this irrigation pump. So you can raise the height. Many of my colleagues, especially like Dr. Sai, I think we use only the without the pump, but it may be helpful to some of us, and ultimately it near the end of the procedure it's important to kind of reduce the pressure and check for the bleeding, because that might be the cause of your epidural hematoma. You will be mostly using this probe, other than the thicker probe which you will use for clearing the muscles when you enter initially just the attachment, just to find the point from where you have to start the drill work. So for anesthesia, so 10 years back I was doing anesthesia. Now it's 10 years since I have shifted to the pain practice. So epidural anesthesia with mass sedation in the prone fixed position on a Wilson frame is the ideal thing which you should aim for. But of course, it depends on your choice. Can be done under GA as well. I personally prefer the first option because that's what I learned and that's what I studied. So OT setup is extremely important, and this is often ignored, especially by beginners. So when this is Dr. Lim's OT, I think. Yeah, so this is a picture which we took in his OT, and you can see how the silicone pads are there to make the patient comfortable, and this is a highly padded Wilson frame which is used, and of course the table height has to be adjusted as per your height. Then there is no other special equipment which is there. However, to keep the patient's head stable, you may use this silicone head rest, and this is often ignored, and as a result patient keeps on shifting like this or like this, and then it's going to be difficult if he's not properly sedated or if he feels uncomfortable. Equally important is the foot end, and this is something which is ignored, and I think below the knee and as well as knee should be slightly flexed, and other than the hip flexion which you require, if knee is slightly flexed and the feet are resting comfortably on foam, this is also going to make a lot of difference. So I saw this, and then in my first case, so I think Dr. Sai was there with me on my first case, and we started with this. So this was quite a struggle for us to get the patient in appropriate position, and I thought it's okay. I mean, let's see how the things go on. But throughout the case, we struggled a bit, especially in one of the cases where we had to do multiple levels. So then I think this is something which you should not ignore as a beginner. So OT setup is extremely important, and after this I purchased a Wilson frame and made it almost similar like what Dr. Lim uses in his place. So thank you very much. This was my experience. I hope you can learn from it and add to it. Thank you so much.
Thank you, Dr. Verma.
So I have a question about that irrigation pump.
Yes.
Which pump you use the pressure?
So
do you add something to saline like epinephrine or?
No. Not adding.
So pressure, how is the pressure?
So pressure, the same Scopy pump which is there, the same is used. Yeah, and I'm right now I'm using mostly the gravity because I work at different centers, so I raise a little more. I have a special stand which is kind of a longer one, but I think it won't matter much once you start, unless if you are having the hypertension with the patient. So that's going to help you out.
It's a good question. So irrigation definitely matters for the things where you're doing for. Since we are using stenoscope, the advantage is the scope diameter is quite small compared to larger scopes or like UBE surgery, where the irrigation goes in and goes out. So until unless the end point is fixed, like you're on a phlegm or your bone, just the gravity irrigation is good enough to maintain the less bloody field. Once phlegm is open, depending upon the epidural blood ooze, depending on that, you can add up the pressure. But unless you have a fixed end structure, like until you open the phlegm, gravity is good enough to do the procedure.
Next question.
Yeah, so one comment which I would like to elaborate on what Dr. Sai said. So when you are doing a monoportal, your vision is where your flow is coming from. So automatically it is the highest pressure, I think, will be on that field. And your vision will be relatively clearer, as opposed to if you are doing a biportal, you need to point it in the direction because your flow is coming through one of the thing, and both are mobile. So you have a higher chance of
No. In the biportal, the important thing is the egress of the water content actually. It's not the pressure. Once you start increasing the pressure in biportal, then the things become cloudy, you know.
Yes.
Because if the outflow is not good, then the whole surgery is a mess otherwise.
yes.
Yeah.
One more question.
Dr. Verma, nice presentation. My name is Rustam. I'm from Israel. In Israel, we have no experience with epidural anesthesia during the spinal procedures. And as I understand, in the Asian countries, it's pretty common practice. You know, I am really obsessed to go after the surgery to recovery and to check if my patient moves the toes, feet. What is about epidural anesthesia? How much time takes for patient to regain? Are you less obsessed than me with this?
No, not at all. Actually, all depends on the concentration of the drug which is used. So we used something which is known as sensory concentration. So if you reduce the concentration of the anesthetic, so you will not have a motor block.
Okay, not at all.
Not at all.
So you can.
It's just like think of a walking epidural, like how they use in labor analgesia. So they take an epidural, but they walk, and it's a similar thing.
Okay.
So I think your anesthesiologist will be knowing this already. Okay. Just talk to them and tell your requirement, and they will do the needful.
So it's probably a light marcaine you use?
Yes.
Yes?
Yes.
So we are talking about the fluid medium. So any kind of monoportal or biportal surgery is not always the pressure what you build in. So the fluid, it should be a layer so that the medium is opened up so that you can see what is inside. So once you dissect the muscle layer, if the fluid medium is good enough, which is enough to dissect the soft tissue around, the vision is good. Sometimes if there is no good amount of fluid irrigation available, you just increase the pressure also if it is targeted to only one place, so you may not get good vision.
Yeah, I have a question to Dr. Verma and to the other speakers also, because mainly we do is under local anesthesia, every lumbar pathology. I have a question is during surgery in your practice, after sometimes some patients are having neck pain. In your practice, do you have the same situation?
Quite frequently, like, you know, if you are having the high pressure situation, when you are pushing the irrigation fluid with too much pressure, then sometimes the patients start complaining of neck pain, and that's the point which one has to be beware of raised ICT actually. And either you can stop the procedure, either can pause the procedure for a few minutes, or can reduce the pressure. These are the two things that I do usually, and that works, I guess.
Are you also using a pump?
No, I don't use pump. It's natural gravity.
Natural gravity.
Yeah, but still, yeah. No, not like before. Before we use it pump. Now is only natural gravity, but still some patients are having neck pain.
Okay.
Dr. Lim, do you have also same thing in your practice?
So sometimes we have the patient felt the neck pain during the operation is related to the pressure of the pressure of the water irrigation. So sometimes you can't head up. It can be the better head up, right? Ask the anesthesiologist. And about the question about the local anesthesia, to recover from the local anesthesia, it will take 6 hours usually. So, but one of the advantages of the local anesthesia can be during the operation, you can make the conversation between the doctor and the patient is very important. Sometimes we can ask the patient, "Are you okay?" Yeah, the conversation is better than the general anesthesia, but it will take 6 hours to recover from the local anesthesia. So head up, I think head up is better.
Thank you, Dr. Lim. No questions? Any questions?
One suggestion, like in cases, if we have, particularly in the cases where we are working with the case of stenosis particularly, so it's always better to do all your bone work before opening the ligamentum flavum. That saves you a lot of from the pressure point, I guess.
Thank you, Dr. Verma. Our next presenter, Dr. Shomansor. His topic is endoscopic removing disc herniation using PSLD method.
Dr. Lim, I would like to ask, my presentation is very similar to Dr. Verma's presentation. So maybe for the audience, I would like to make the presentation on the Russian language, because no question from the audience, so for more understandable situation. Because it's a basic, I did not advanced, but basic presentation. Здравствуйте, уважаемые участники. Я попросил разрешения сделать презентацию на русском, так как это очень похожая презентация, на которую сделал спикер до меня, доктор Верма, поэтому презентация будет на русском. Меня зовут Шомансур. Я работал в частной клинике в ProfMedService, но до сих пор я там числюсь. Кроме этого, я еще сотрудник научного центра травматологии-ортопедии, который тоже участвует в этой конференции. И я бы хотел рассказать вам вкратце, что такое PSLD и в чем отличие от других интерламинарных доступов, то, что вот использует, например, доктор Петр в своей операции, в чем отличается от эндоскопов Ричарда Вульфа и почему он называется именно PSLD. Но вначале хотелось бы сказать насчет дегенеративных заболеваний позвоночника. Почему эта конференция сейчас очень популярная, да, эндоскопическая? Потому что дегенеративные заболевания позвоночника все больше и больше как бы статистически встречаются все чаще. Это большинство зависит от того, что общество, как бы aging society, наша как бы средняя продолжительность жизни растет, все как бы пожилых людей становится больше, и пациентов со стенозами становится больше, и образ жизни, то есть lifestyle у нас такой стал в последнее время, что ну, если вы вчера там доктор Радченко докладывал про мышечную массу, которая окружает поясничный отдел и вообще в целом позвоночник, все чаще встречаются как бы недоразвитие, то есть саркопения вот этих мышц, и в результате этого развивается и как бы дегенеративные заболевания, и как бы грыжи диска. Поэтому это статистические данные, но то есть это сейчас самая актуальная тема в наши дни, то есть иметь у себя в арсенале эндоскоп, чтобы лечить вот этих всех пациентов, которых с годом в год будет становиться все больше и больше. Это статистика про публикации, то есть, как вы видите, во всем научном мире эндоскопические операции на позвоночнике обсуждаются все больше и больше. То есть все больше и больше хирургов переходит на эндоскопический метод лечения, чем традиционный метод лечения. Первые интерламинарные доступы еще начали делать в середине 2000-х годов, то есть 2006 года, 2008 года есть публикации, когда использовались интерламинарные доступы, это делали Ричард Вульф и Макс Мор. Основная разработка доктора Лима, то есть PSLD, это в первую очередь модификация самого эндоскопа, то есть эндоскоп имеет определенную специфику свою, то есть у него рабочий канал 5,5 мм диаметром, а наружный диаметр 8 мм. А длина рабочего эндоскопа это 12 сантиметров, рабочая длина, это то есть длина самого как бы рабочего канала. И это дает как бы очень большую возможность для маневрирования, то есть при помощи одного эндоскопа можно делать как бы все патологии позвоночника, то есть бипортальную, то есть билатеральную декомпрессию, то есть декомпрессию через один прокол в нескольких уровнях. Как бы можно лечить и стеноз, и грыжу одновременно, и как бы и фораминальный стеноз, можно делать все заболевания позвоночника, то есть от шеи до поясницы одним скопом. И кроме эндоскопа доктор Лим еще сделал, как бы модернизировал доступ свой, то есть используется именно доступ, где рядом с остистым отростком имеется жировая как бы прослойка, и через именно вот эту прослойку делается доступ. Кроме доступа еще как бы инструментарий, как вы видите, ну, то есть чуть-чуть размазанные, так как шрифт маленький, но вот на разработке именно вот этого как бы набора от Макс Мора и другие южнокорейские компании как бы производят свой набор инструментов по идее доктора Лима. То есть это как бы укомплектованные инструменты, то есть там 5 наборов кересонов, 2 кусачки и диссекторы, и как бы очень просто и очень удобно как бы, да, использовать их. Что касается самой операции, то есть я в основном 90% своей операции я использую именно этот метод, то есть метод PSLD. То есть это делается именно этим эндоскопом, интерламинарный доступ или параспинальный. И как бы можно удалять и грыжу, и делать как бы декомпрессию. Хочу привести в пример несколько кейсов. Например, как вы видите, вот грыжа, мигрированная вверх, upmigrated, до и после операционные снимки. И как вы видите, обратите внимание на состояние пара, ну, вот тоже. Не будет работать, да? Well, обратите внимание на состояние паравертебральных мышц, то есть до и после операции практически мышечные структуры не разрушены. Это основное преимущество, то есть эндоскопических операций. И желтую связку как бы с противоположной стороны тоже сохранена, то есть удалена грыжа и как бы основные анатомические конструкции, элементы сохранены, да, позвоночника. Вот следующий, например, пример. У нас в стране многие невропатологи, ну, не хирурги, определяют показания к операции по описанию снимка, да? Многие из вас сталкивались, наверное. То есть и пациенты тоже обращают внимание на описание МРТ. То есть в МРТ, например, могут там радиолог написать 3 или 4 миллиметра грыжи, да? И многие пациенты говорят, грыжа маленькая, стоит ли оперировать ее открытым доступом, как бы консультироваться с врачами, да? И этот эндоскопический способ, то есть позволяет как бы у таких пациентов, у кого имеется относительно маленькие размеры грыжи, но с сильными симптомами, как бы лечить хирургическим путем, не дожидаясь как бы длительных консервативных лечений. Как бы вот этот дооперационные снимки, это оба, то есть просто 2 среза аксиальных поставил, а это послеоперационные. Как вы видите, там агрессия в отношении фасеточных суставов минимальная, да, то есть можно аккуратно зайти и интерламинарно убрать саму грыжу, не разрушая никакие важные анатомические структуры. Вот еще один пример, как бы грыжа секвестрированная. И внутри диска тоже, как вы видите, высота диска особо там не опущена, коллапса диска нету. То есть еще одно преимущество эндоскопической операции, как бы это позволяет сохранять содержимое как бы внутридискового пространства. То есть если диск внутри диска относительно здоровый, то есть он полностью не дегенерировался, то его можно как бы полностью не очищать, а как бы просто удалить секвестр и как бы оставить диск на своем месте. Так, это вид операционный, как удаляется грыжа. То есть, например, большой секвестр, да? На видео можете обратить внимание, там вот этими форсепсами удаляется. То есть иногда возникают вопросы у многих хирургов, кто не знаком с эндоскопией, можно ли удалять большие размеры грыж, да? Это не создает никаких проблем. То есть, как вы видите, рабочий канал 8 мм, и туда помещается грыжи просто огромных размеров, и это не мешает. И можно удалять кусками. И на следующем видео можете обратить внимание, как мышцы, да, после операции, они во время удаления вот этого эндоскопа самого, как они смыкаются, да, и как бы их основная масса как бы не разрушена, и задняя большая фасcia лата тоже как бы минимальный разрез. И после операции на вот этом снимке можете обратить внимание, желтая связка, она практически тоже на своем месте. То есть это позволяет как бы избежать рубцовых процессов, вот этого спаечного процесса внутри эпидурального канала. И дефект на самой коже, то есть на картинке слева операция на микроскопе, то есть микродискектомия, а справа это послеоперационный шрам от эндоскопических операций. Это тоже большой плюс в пользу эндоскопических операций. Кроме этого, одно из самых больших преимуществ эндоскопических операций – это возможность избежать послеоперационных инфекционных осложнений. Это в первую очередь связано с тем, что нету прямого воздушного капельного контакта с эпидуральной полости, да, и с наружной поверхностью. То есть из-за того, что постоянно используется ирригационная помпа, вода как бы считается барьером между эпидуральным каналом и вообще операционной раной и с наружной поверхностью. И поэтому вот больше 1300 операций сделали, и ни разу как бы инфекционных осложнений в виде спондилодистита у нас в моей практике еще не наблюдалось. Для минимизации кровопотери, для контроля кровопотери очень важно иметь хороший абилятор, то есть высокомегагерцный, выше 1,7 МГц должно быть. Но в идеале, конечно, было бы здорово, если бы абиляция имела, например, мегагерц где-то 4 сейчас есть такие компании, которые предоставляют такие хорошие абляторы. И еще очень важно иметь высокоскоростной алмазный бур. Это, во-первых, позволяет работать безопасно, и, во-вторых, это тоже в какой-то степени позволяет контролировать кровотечение самой раны. Когда работаете алмазным буром, кровотечение из губчатой кости гораздо меньше. Еще одним преимуществом эндоскопической операции – это короткий срок реабилитации. То есть ваши пациенты, когда у вас на руках имеется вот эндоскопический метод лечения, они очень быстро реабилитируются. То есть стационарное лечение в среднем 2 суток хватает, но кто-то держит 3. Но у меня были пациенты, которые утром оперировались и уже вечером уже выписывались домой, да, как бы не требуют особого ухода. То есть сейчас в современном мире, то есть в этом обществе, где человек не может просто исчезнуть из своей как бы рабочей деятельности и иметь под рукой эндоскопические операции, это очень важно, потому что пациенты не могут месяцами, там, по полугода находиться в реабилитационном периоде. Поэтому эндоскоп в моем видении будет развиваться все дальше и дальше. И поэтому очень важно овладеть этой техникой в начале. Это результаты, которые я имею. То есть мы с доктором Якубовым начали делать операции с 2018 года. У него уже больше 1500 операций. Мои личные операции – это больше 1400 операций. Общее количество больных 1100. Это, конечно, примерно взято, но почему разница между операциями? Потому что у некоторых больных по 2 операции, то есть несколько уровней операций или рецидивы иногда приходят. Множество операций, то есть 60% операций – это операции по удалению грыжи, а 35% – это операции по стенозам. Но тенденция меняется, то есть все больше и больше операций мы делаем по стенозам. И менее 1% – это остеоидная остеома, синевальная киста, и такие пациенты оперируются. Из осложнений могу сказать, в начале, вот, когда еще опыта не набрались, очень часто встречались повреждения дурального мешка, то есть примерно у 20% были повреждения. Это в большинстве случаев удавалось ушивать или закрывать суджисилом или тахосилом, да? Но в одной случае, конечно, пришлось открываться, то есть делать конверсию операции, ставить микроскоп, потому что после пробуждения у больного еще до сих пор чувствовалось как бы ущемление нерва в дуральном мешке, и пришлось открываться и ушивать дуральный мешок. Повреждение оболочки корешка у 5 больных, но они все полностью восстановились. Рецидив грыжи и парестезии я хочу остановиться вкратце в следующем слайде. Например, вот это исследование, да, как бы сделано в 2017 году именно по позвоночной эндоскопии, то есть это ретроспективное исследование. Взяли одного конкретного врача из Китайской Народной Республики и сделали как бы все его 501 истории болезней по операциям эндоскопическим. И сделали анализ, то есть первые 100 больных, сколько было осложнений, и после 100 до 500 больных, сколько процентов осложнений. То есть это относится как бы к кривой обучения, да. И как вы видите, там на столбике слева первые 100 операций у этого врача как бы процент осложнений был 18%. Это там брались неполная как бы декомпрессия или невозможность удаления грыжи, да, эндоскопическим путем, повреждение нервного корешка или как бы дурального мешка, парестезия послеоперационная и рецидив грыжи, то есть ранний рецидив. И обратите внимание, что на колонке справа, то есть в операциях от 101 до 500 как бы процент осложнений у этого врача снизился до 3%. И как бы это очень важно, потому что это как бы кривое обучение для начинающих, это как бы очень важный слайд, потому что вначале у всех будет какие-то осложнения, да, вот в виде там повреждения нервов, но это не должно вас останавливать от того, чтобы учиться этой методике. Это потому что после уже 100-й операции у вас уже начнутся появляться, будут очень хорошие результаты. Спасибо за ваше внимание.
Спасибо, доктор Шамансур. Thank you, доктор Шамансур. Any questions? Вопросы есть по поводу доктор Мадамин-Джон? Вот микрофон рядом с вами.
У меня вопрос вот такой. Срединная грыжа, большая срединная грыжа. Вот насколько я видел ваше видео, вы смотрите, как с инструментариями делаете мобилизацию нервных структур, да, и потом удаляете. Если оно латерально расположено, оно не предоставит никаких трудностей. А если вот большая грыжа, именно срединно расположенная, и иногда мы откроем, как эндоскопически не сможем найти разрыва фиброзной кольца. Самого грыжа мы не видим, просто выпячивание, как протрузию, экструзию мы видим. Тогда какая будет ваша тактика? Почему я спрашиваю? Вот, я тоже эндоскопист, но мы работаем более тонкими эндоскопами. Мы зайдем внутрь канала. И с этим портом мы самого отодвинем саму нервную структуру. И мы удаляем. А если вот PCD, тактика будет какая?
Я понял ваш вопрос, мадам Найке, спасибо. Да, действительно очень хороший вопрос. Центральная грыжа, это в первую очередь надо, мы смотрим на симптомы, то есть какая нога больше беспокоит. Первый вопрос стоит, с какой стороны делать доступ. Например, центральная грыжа может давать как бы и налево, и направо. Мы смотрим в основном, в какую сторону дает симптом, и делаем доступ. Доступ в основном отличается тем, чем как бы относительно латеральной грыжи, да. Но мы разговариваем про поясничный отдел, не про шейный, не про грудной, а поясничный, да. Делаем как бы не флавиотомию, да, как бы не просто разрез желтой связки, а как бы больше с верхней края прикрепления желтой связки полностью удаляем желтую связку. И даже частично с контралатеральной стороны удаляем желтую связку, чтобы как бы мобилизировать дуральный мешок, чтобы когда мы делаем медиализацию дурального мешка, он не зажался между как бы желтой связкой и как бы с этой большой грыжей. И потом как бы убираем вот эти все перидуральную оболочку и все эти спайки, если они образовывались, и делаем медиализацию дурального мешка. И если задняя продольная связка целая, вот как бы нету, да, разрыва задней продольной связки и как бы сам секвестр наружу не торчит, мы просто специальными как бы scissors punch, то есть специальные как бы ножницы эндоскопические, они заходят через специальный инструмент, который называется root-ретрактор. То есть root-ретрактором отодвигаем дуральный мешок, разрезаем заднюю продольную связку, ищем секвестр, он легко находится крючком, и как бы тизинг, то есть его чуть-чуть латерализацию делаем самого как бы фрагмента и удаляем при помощи аллигаторных щипцов. Это как бы, то есть делаем более агрессивную медиализацию дурального мешка, чтобы дойти до центра, где находится грыжа. И потом у нас же есть МРТ-снимки, как бы до операции мы знаем, как бы, насколько надо медиализировать, насколько она центральная или основание есть, чтобы можно было где ухватиться. Как бы почти что одинаковое относительно латеральные грыжи, но просто более агрессивное удаление желтой связки и верхней дугоотросточного сустава, то есть SAP. То есть медиальную часть SAP удаляем и легко можно сделать доступ. То есть от размера эндоскопа особо не влияет на расположение самого секвестра.
Настолько я понял, что сперва вы начинаете дискэктомия, затем секвестректомия, да?
Нет. Outside-in. То есть сразу удаляем сам секвестр. И потом заходим внутрь диска.
Спасибо.
Вопрос?
Противопоказания эндоскопической дискэктомии.
Противопоказания, да. Ну, противопоказания это как бы в первую очередь это нестабильный спондилолистез, то есть если позвоночник требуется как бы фиксировать, фьюжн надо делать, то это как бы, ну, можно как бы перкутанную фиксацию с установкой кейджа, но для меня сейчас пока этот уровень еще не достигнут, поэтому если спондилолистез, то я его стараюсь открытым доступом делать. Инфекционные заболевания или там повреждения, еще инфекционные заболевания и онкологические заболевания пока еще невозможно. Например, интрадуральный какой-нибудь этот опухоль или экстрадуральный, это как бы эндоскопом пока невозможно делать. Поэтому вот такие.
Есть еще вопросы?
Да. Рецидив после открытых операций эндоскопическим доступом делаем. Это зависит от как бы уровня, да. В основном рецидивы, конечно, удобнее всего делать трансфораминально, потому что как бы идешь с девственной, да, структурой, где нет рубцов. Но интерламинарно тоже рецидивы после открытых операций делаем. То есть заходим как бы более латерально, стараемся в первую очередь найти как бы SAP, что как это лендмарк, да, для нас. Находим SAP, там частично удаляем. Но если после открытой операции там как бы сохранился участок здоровой желтой связки, я стараюсь найти вот этот здоровый участок, где нет рубцов элементов, открыть желтую связку, увидеть вот этот дуральный мешок, визуально его идентифицировать, там все жировые ткани, и потом уже со здоровой части стараюсь спускаться либо каудально, если я снизу открыт, либо краниально в сторону диска, где имеются рубцы, чтобы не повредить вот этот дуральный мешок. Но в основном, основной этот мой доступ при рецидивах интерламинарный. Я стараюсь идти более латерально в сторону SAP, найти SAP, как бы его частично убрать, потом с латеральной части более медиально заходить стараемся. Как бы, как... Нет, бод используем. Бод используем. Да. Да, вот. Имеется в виду этот бод? Да, да, используем. Ну, убрать кости используем, да, без проблем.
Есть еще?
Думаю, такие, мадам на кем сауал говорит.
Отличается ли?
Да, я понял вопрос. Да, конечно, если у больного... В первую очередь обращаем внимание на патологию свертываемости. Да? Если, конечно, имеется какие-нибудь проблемы с свертываемостью, то его, конечно, стараемся на эндоскопически не брать, потому что если будет кровить, то невозможно будет полноценно сделать операцию. Касательно артериального давления, то это как бы занимается кардиолог, терапевт, он нормализует давление и вместе с анестезиологом решают, да. А сахарный диабет, ну, больше смотрим на, как это называлось, гликемированный гемоглобин. То есть, если он слишком высокий, то стараемся не брать. А если сам сахар он высокий, то его можно легко контролировать диетой и инсулином, и понижают, и делаем. А так, если очень высокий гликемированный гемоглобин, то этих пациентов не берем на операцию, ждем, пока этот эндокринолог сделает свое дело. Там, стандартную, то есть, ну, было дело, ванкомицин, водяной раствор добавляли, неомицин, но сейчас это уже не делаем. Как бы стандартный ципрофлоксацин, перорально, то есть после операции, а во время операции цефтриаксон по 1 грамму во время операции, утром, вечером по 1 грамму. Стандартная антибиотикопрофилактика, ничего особенного.
Дисцит и грижа. Какова будет ваша тактика? Дисцит и грижа.
Дисцит и грижа. Ну, вообще, вот участвуем в конференциях и видим, да, что спондилодистит вообще эндоскопически они оперируют, там делают санацию самого диска, там убирают вот эти все выделения, то есть экссудат и воспалительные медиаторы. Но в моей практике не было такого, чтобы грыжа дистит было. Но если придет, я думаю, эндоскопически реально его можно взять, убрать секвестр, то есть саму грыжу, очистить полностью диск и назначить больному как бы постельный режим строгий и делать антибиотикопрофилактику. То есть это не мешает. То есть убрать грыжу. Но я бы в таком случае добавил бы в ирригационную воду, как бы ванкомицин или гентамицин, что-то такое, чтобы промыть полностью внутрь диска и после операции ведения больного строго постельный режим и антибиотики. Да, так. А так в практике еще ни разу не было да, такого.
Есть еще вопросы? Ага. Спасибо, доктор Шамансур. Наш следующий доклад. Next presenter is Dr. Santosh. And the topic is posterior cervical endoscopic discectomy and foraminotomy.
Good morning, everybody, and thanks. I would like to thank organizers and especially Professor Lim for inviting me on this forum to speak on the topic of posterior cervical stenoscopic decompression, what we call as PSCD. And as we know, like the posterior approaches to the spines, there are three approaches mainly: microscopic and the tube assisted, as well as now the full endoscopic. So gradually there is evolution from microscopic to tubular and tubular to now endoscopic, fully endoscopic. And as we can see in all these pictures, like the visualization is the key factor, particularly for the patient as well as for the surgeons regarding the safety of any procedures. So we can see in all the three pictures, there are the pictures for the same procedures, but first one is from the tube foraminotomy, and second is for the microscopic, and third is endoscopic, full endoscopic. So as we can make out, like the full endoscopic, the visualization is very, very better because of the irrigation medium. So it increases the comfort as well as the safety and visualization. So what are the indications for the full endoscopic foraminotomy? So any kind of disc, like which is in the foraminal region or the paracentral region, can be done with this approach. Even larger herniations with major component which are mostly paracentral can be done with this. And even moderate foraminal stenosis can be done. The only contraindications of this is the central disc herniation or the calcified disc, which cannot be dealt with the posterior approaches, and for that you need anterior approaches. So what are the scopes that we can use? The standard scope normally which we use is 4.1, but maybe we can do it with the stenoscope also. So for me, I am doing it with the stenoscope, that is having the working channel of about 7.1 millimeter. So anyway, you can do it with the smaller scopes as well as the larger one. So I do have just one scope, that is the 7.1 working channel. So I am doing it lumbar as well as cervical approaches, both with the same scope. So I would say 7.1 is a universal scope which you can use even for the cervical as well as for lumbar. And when we do posterior cervical procedures, one has to be careful about the positioning of the patient because it's very, very important. And these procedures can be done only under general anesthesia, and the patient needs to be in prone, and the head needs to be stabilized on the Mayfield retractors. And the position of the patient is very important. It has to be kept in the reverse Trendelberg position. And for the patient comfort, a roll towel has to be placed under the chin to keep the neck in the little flexion just to open up the interlaminar space and to have a better anatomy. So before starting the procedure, one need to have a good orientation about the anatomy, particularly radiographic anatomy, and we need to mark certain lines for the proper trajectory. So the most important thing is when we initial view is the AP view, and after positioning the patient, and we need to mark, because here I'm talking about something very basic, but we need to know about it. Particularly, you need to mark the mid-pedicular line or the medial pedicular line or the mid-line. There are 3 lines which you can mark. Our target is basically the medial pedicular line, where you need to land up, because we always need to land on the bone. So bone is our friend, so not to go toward the canal, it has to be the medial pedicular line of the articular pillar or the medial pedicular. Here we can see. And in the lateral view, it's important to mark the disc line actually. So this is very important. So as we can see in this picture, the angulation is cranial to caudal angulation actually. This angulation is very, very important because if you want to reach the foraminal area without much bone resection and without destroying the facet, so this angulation is very, very important. This is slightly different in comparison to the lumbar, where we usually have caudal to cranial angulation, but in the cervical it's from cranial to caudal angulation. And another important line is the facet line that you can draw. This line is going to the facet, although it's not very important, but still you can mark it. Otherwise, the disc line as well as the medial pedicular line are sufficient enough. And the ideal trajectory has to be between the facet line and the disc line, because with this kind of trajectory, if the bone resection is very, very little, and you need not to struggle to find the nerve root. So this is the ideal trajectory, I can say. And here you can see the landing of the sleeve on the medial pedicular line or the midline of the articular pillar. This is a safe zone, and this is a safe trajectory. And to summarize all these lines, you can see marking of the midline, marking of the medial pedicular line, and marking of the disc line, and the landing of the needle or the initial dilator. Because landing on the medial pedicular line, I'm emphasizing so much on it because when you land up laterally, then there are chances of sliding your scope into the neck muscles, and sometimes you can produce hematoma or swelling. And when you go to medial, then you can go directly into the canal, and that nobody wants to be there initially. And other important step is before proceeding with this with the dilator, introducing a dilator and making a cut, you can use your needle initially 16 gauge or 18 gauge needle, and you can after placing the needle you can change check your trajectory whether you are at the right trajectory or not. If you are at the right trajectory, it's good. If otherwise, you can change your trajectory a little bit, cranially or caudally. So C-arm visualization is very, very important, particularly in the AP and the lateral view all the time. And after putting the needle and after checking the needle, if you are at the right place, then you can make a skin incision and a stab incision under the C-arm. And second important thing is, like while making a skin cut, it has to be deep cut, and because the fascia is very strong in the neck muscles, so you need to be you can visualize the incision blade in the fluoroscopic view, and after that you can put blunt dilators to dilate the muscles. And while putting the dilators and while introducing the dilators, it's very important not to push very hard. Just go with the rotating movements and just try to feel the bone with your initial obturator. And confirm your trajectory under the C-arm again and again, particularly in the initial few cases. And after that, you can introduce a scope and can see the soft tissue and clear the soft tissue with the cautery. And the important thing is to have the orientation on your screen, whether what is caudal, what is cranial, what is lateral, and what is medial. And once you are there, the important thing is to identify the landmarks before starting any kind of drilling or using any kind of punch. So this is the anatomy which you can see. This is for the C6, C7 interlaminar space. So here on the 6 o'clock you can see the facet joint, and 12 o'clock you can see it's a epidural space, and C6 is cranially the C6 lamina, and caudally is the C7 lamina. And so this, before starting anything, you need to have this kind of picture in your mind and on the screen. So this is very important. And rather than going medially, I would say just stay on the facet or the articular pillar and take out the soft tissue, and you can expose the facet joint, and you can see this V point, what we call as V point, which is the starting point of the cranial and the caudal lamina. So this is very important landmarks, which is the medial edge of the facet joint, the V point. And drilling, you can start from the cranial lamina and go toward the facet and caudal lamina. So here in this figure you can see, so much better in this picture you can see, this is how you can drill. You should always start drilling from the cranial side and go laterally toward the facet joint, and then come to the inferior lamina. So the basic steps are basically three. First is the hemilaminotomy, and second step is basically the identification of the index nerve root in this procedure. So here you can see in the first picture, after exposing the bony anatomy, we can see, we can make out cranially is the lamina, caudally is the inferior lamina, and toward our side is the joint. And we start drilling from the cranial lamina, and second part we can see in this third photo, we can see like it's the ligament exposure of the ligamentum flavum a little bit. And the third thing, after opening the ligamentum flavum, you need to see identify the nerve root, because the nerve root is covered with the very thin membrane, where that is known as the perineural membrane, or that is basically an inner layer of the ligamentum flavum. You need to identify and separate that layer with your hook, and to identify the nerve. And you can use your dissector, or you can use your nerve hook to separate that flimsy layer from the nerve root, and have a better orientation of the nerve root. And the second step is after identifying the nerve, and after identifying the anatomy, cranial lamina, caudal lamina, and the facet joint, and after taking out the ligamentum flavum, and you need to do little more drilling on the lateral side just to have a better identification and better exposure of the nerve root. So how much, this step is known as the foraminal decompression, and for how much decompression has to be done, first initially you need to take out drilling, start drilling cranially, and then come to the facet and start drilling the facet as much as up to the 1/3 of the facet. And once you start done the 1/3 resection of the descending facet, you start seeing the ascending process in a better way, and then you start resecting the superior articular process and till the pedicle. So how much drilling has to be done, because more than 50% resection of the facet joint can lead to instability, so better not to do that. But the exposure of the root up to the lateral part of the pedicle is good enough for the adequate decompression of the nerve root. So here in this case we can see, and sometimes as yesterday we had a lecture about the necessity of the pedicle resection for having a better space around the nerve root for the decompression, but it's not necessary in all the cases, but sometimes you need it, particularly in the cases where the nerve root is very much compressed and it's hard, so you need to take out a part of the pedicle. Do a pedicle resection. You can do either with the chisel, small micro chisel, or you can do it with the shaver. And after shaving the pedicle, you can get a lot of space in the axilla that allows you to use your retractor and use your instrument and take a little bit of space to take out the hard disk fragments. And for that you can use a trephine or micro punch to take off the annulus. And there is a concept called 360-degree decompression around the nerve root. Although, as we all know, the dissection and the manipulation of the cervical nerve root has to be minimum without much retraction, because the chances of neural injury are much more as compared to the lumbar region, and this territory is less forgiving as compared to the lumbar region. So the neural manipulation has to be as little as possible, but that's why we need a pedicular resection just to create a space around the nerve root. And sometimes the osteophytes and the pathology is ventral to the nerve root, that has to be taken out. So for that thing, we need to retract the nerve root, and that can be done by retracting the nerve root rostrally rather than doing it caudally. And you can use your nerve root retractor and either use manual terfines or other things, micro punches, to take out the bony elements below the. So that step is an optional. Otherwise, just the dorsal decompression is good enough in most of the cases. But when you are it's very obvious on your MRI or the imaging, there is an osteophyte complex beneath the nerve, then you need to do the little bit of retraction, but not much. And it has to be very brief for your safety. And I will show a video, and before that, a few words about the utility of this approach, particularly in the cases of compressive myelopathy or central stenosis. And this technique for the myelopathy decompression is quite useful in the patients where the pathology is dorsal, the compression is dorsal. It's not useful in the candidates which have anterior pathologies like fixed kyphosis, osteophytes, and dynamic segmental instability. But for the cases, particularly in the aged age group, elderly age group, we have other comorbidities, which those cases are not suitable for the extensive procedures like the laminoplasty or other disc fusions, ACDF, and lateral mass screw fixation. In these cases, we can consider the possibility of endoscopic decompression posteriorly in the cases of the myelopathy. And particularly the patients who have extension of the neck, particularly because of the thoracolumbar kyphosis, they tends to keep the neck in the extended position. Those are the right patients because the pathology there is posterior and the compression is posterior mainly. So that can be addressed with this posterior cervical ULBD. So again here the marking will remain the same, the AP marking will remain the same. And in the lateral, the ideal position of your scope has to be in the line with the disc space and between the spinous process. So the only difference between the foraminotomy and you can say in the dorsal ULBD is the extent of the bone resection basically. So the target area and the landing will remain the same, and you expose the superior lamina, inferior lamina, the facet, just because the neck is in the hyperextended position, so the interlaminar space will be narrow and the spinous process will be juxtaposed, so you need to take a little more bone as compared to the routine foraminotomy in cases of ULBD. So these are the basic steps where you can see again the drilling of the cranial lamina, caudal lamina, facet. But here, just because you are not doing foraminotomy, you are just doing just central decompression, you need not to take out a lot of SAP or IAP in these cases. Just removing the central ligament and the contralateral ligament and is enough to decompress the dura. But going to the contralateral side itself is a challenge, because in these cases the spinous process are juxtaposed and they are very close to each other and the space is very narrow. So just to reach the opposite side, you need to drill a lot of cranial lamina and need to drill a lot of the base of generous drilling of the base of the spinous process just to reach on the upper level. And while doing so, it's very important to take care, like you should not touch your dura with your scope or your sleeve. You should keep it floating all the time, not to press the dura just to produce any neurological complications. And this is how you can go with the help of your drill. You can drill the contralateral lamina also and take out the ligamentum flavum with your punches. And what is the end point? The end point is basically the visualization, ipsilaterally the visualization of the lateral margin of thecal sac, and contralaterally also the visualization of thecal sac. So that you can check on the AP also, AP view in the CM also. So this is it, and I would skip slides. So what are the pitfalls? So the most important thing is, like in the cervical, the chances of doing the wrong level surgery are very, very high, because you have to be sure all the time on your CM whether you are at the right level or not, because the skipping of the cannula is very, very easy, because if you're proceeding with the C5-6, the sliding to C4-C5 and C5-C6-C7 is very, very easy, and you don't know sometimes, like, and you can go land up in the wrong level also. So always keep check in the lateral view whether you are at the right level or not. Always tends to be try to be in the line with the disc space. So the initial starting point has to be little cranial as compared to the lumbar pathologies, and so the benefits of full endoscopic cervical procedures is it's done under irrigation, so the visualization is excellent, and there is hardly any bleeding otherwise, but that bleeding can be controlled with the meticulous radiofrequency use, and saline itself acts as additional dissecting tool to create separation between the natural planes. But the posterior approaches are not suitable for central herniation, calcified herniations with instability and severe axial neck pain. So these are my pictures basically. I marked the midline in this AP view and the mid-pedicular line here. And here you can see the mid-pedicular line and the docking of the sleeve on the articular pillar in the midline, middle pedicular line, and checking the position in the lateral view. And after going in, after the resection of the soft tissue, I can see here cranial lamina, caudal lamina, and here this is a much better picture. You can see. And this, once you start drilling, the ligamentum flavum automatically starts to get separated, and this is the V point here, and this is the identification of the nerves. This is cranial, this is caudal, and you can see the pedicle, little bit of pedicle also. And can I play the video a little bit here?
Video?
Yeah. Let's go. Stop. Need to stop this. Exit.
Exit. Save. What is your video?
Videos.
Save. Can you choose?
Video. What? Yeah, this one. So this small video, this is initial landing and the soft tissue clearing. There's a case of formal stenosis, C5, C6 level. So after clearing the soft tissue, identifying the structures, and start drilling the cranial lamina and then caudal lamina. Yeah. And thereafter you can use your punches. Here I am using the bigger scope, 7.1 millimeters working channel scope. So I can use bigger instruments, bigger Carrison punches, and bigger drill. It's always important not to press the neural structures with your Carrison punches. If the space is narrow, then maybe you can use the drill initially to thin out the bone, and then either you can use the curate or a thin 1 millimeter Carrison punch to take out the bone. So this is caudal part. Now the ligaments start floating. Now this is exposure of the nerve root. So here is the this is axilla. So most of the times the disc pathology lies in the axilla. So, but you need to free the nerve root from the shoulder as well as from the axillary area. So now this is the pedicle part. Now I'm using the root retractor because I have enough space. So I can use this manual trephine after retracting the nerve root safely. So and after it, I can introduce my forceps. I can use my forceps as a retractor as well as so you can do multiple levels also. Okay, just how to minimize it. Just
next. Do you want next?
Yeah, next.
Next video.
Yeah. Just a minute. This is again the C5, C6 and C4, C5 and C6. For anatomy, two levels. Initially C4, C5. It's the cranial lamina. This is the facet toward the facet. So 1/3 to 1/2 of the facet resection is enough. So here you can see the nerve root, and just trying to take out the, after refining, I am take out the hard lump below the nerve.
You said never let me go. You said never let me go. You said never let me go. You said never let me go.
Now it's another level with the same incision, just to the help of sliding technique, jumping technique. So this is second level, and I'm going to finish it. You can do additional drilling if you are not satisfied with the amount of the bone or the amount of decompression. Then you can come more laterally toward your side with the help of drill. And you can mobilize the nerve with the nerve hook cranially as well as caudally, both. And sometimes you have adhesions. You can break the adhesions with the help of the hook. Sometimes it's only the adhesions because of disc osteophyte complex, which are the cause of the pain. You may not find the disc or any pathology besides the adhesions. So you have to be meticulous and careful while removing these adhesions, and not to push too much pressure on the nerve root. So for additional, you can retract and do pediculectomy and can retract the nerve root. And you can use the manual terfine just to take out the hard osteophyte complex. So you need to free the 360-degree decompression cranially as well as caudally from the axilla as well as from the shoulder. We can see the free nerve root going toward the foramen. So I am the carry sense toward the foramen. I am rotating the scope. So now thank you.
Thank you, Dr. Santosh.
You showed the calcified disc and you said it's contraindication. Why you just don't do the posterior decompression of the calcified disc?
Any pathology which is not central, like if it's the thecal sac, any pathology which is not in the middle 2/3, like it's a 1/3 part and it's just paracentral, either just fully paracentral or just covering the 1/3 part of the dural sac. So I can use this approach, but not for the central pathology.
So if it's central calcified disc, you don't do it.
No,
but if
then I will use the anterior approach.
SCDF,
Yeah.
okay. And post-operative care of the patients, what you do?
Post-op care is as similar as is same like lumbar thing, but the only thing we use we do it under general anesthesia only, not in the local. And second thing is you have to be careful, like because just because you're doing it in the cervical region, the position of the patient has to be in the turnback all the time, and you need to keep a blood pressure around 90-60. When sometimes we keep blood pressure lower after postoperatively also.
No, I'm sorry. I mean the rehabilitation.
Rehabilitation, like we send the patient on the collar.
Okay.
And after stitch removal, we start physiotherapy. Yeah.
So how long in the collar?
Not more than 1 or 2 weeks. Not more than
1 or 2 weeks.
Yeah.
And you start physical therapy after 2 weeks.
Yeah.
Huh? It's very nice. Thank you.
One more question. About bone resection extension. You said that the lateral border of the pedicle should be the landmark for.
The pedicle resection is not a routine part.
No, I mean how much.
Look, like if this is the lamina, cranial lamina. This is the facet. Then you start drilling from the cranial lamina, and start drilling. Keep drilling unless you drill the 1/3 part of it, and then obviously you start seeing the SAP.
Yes, you said 1/3, but when you have endoscopic view, you cannot estimate. You cannot measure
Normally the width is around 4 millimeter. With the you can use your Carison, maybe the width of the Carison punch, or maybe with the help of your hook, you can estimate that how much I am taking it.
If one width of the hook is enough. Or maybe you can use the lateral border of the pedicle as a visual landmark for.
Pardon?
I mean, maybe you visually can, if you can see the lateral border of the pedicle, maybe it can be a sign.
Endoscopically we can see, not exactly the lateral border, like when the tip of the pedicle is like this, it comes like this, and when you can put your hook and can follow the nerve route along the pedicle, and when you see it's free, so I do think it's good enough.
Okay, thank you.
Thank you for interesting presentation. Approximately how many times did you like these operations, cervical spine, and the serious complication of posterior cervical spine surgery is 5-pulse syndrome. This in literature, this around 2 or 3% of occur complication, and what your recommendation or solution to avoid this complication and management?
Yeah, it's true. Like within endoscopy also, we do face complications like cervical transient palsy or transient weakness in the C5 nerve root. So unless, particularly in the imaging, in the pre-operating imaging, if you are sure, like as such, there is no ventral osteophytes or no ventral compression, it's always better just to take off the little part of the bone and the ligament and just free the foramen dorsally only, not go underneath the nerve root, and keep the manipulation of the nerve root as little as possible. So just the dorsal decompression, as Dr. Lim told yesterday. So just taking off the doing a dorsal decompression is good enough. But you have ventral pathology, then you need to create the space around the nerve root. So for that thing, you need to drill the pedicle a little bit and create the space in the axilla, so that then you will get this little bit of space, and moreover you can use your hook rather than using any other instrument. It's always better to use the hook to take out the pathology below the nerve root rather than retracting the nerve itself. So this is the main point, I guess. So that will avoid the potential injury to the nerve, because post-operatively sometimes you do have weakness, and that could last for even for a couple of weeks. So that's very troubling for the patient as well as for the surgeon.
Have your practice had complication?
Yeah, I do have in 2 cases, but it was fortunately it was transient. So they recovered well. So now I'm very very careful about this thing, not to manipulate the nerve root too much. Just keep the manipulation as little as possible.
How many times you operate like?
Normally for me initially it was longer, but now I can do it within 1 hour, 1 hour 10 minutes, 1 hour 15 minutes. Yeah.
Thank you.
Солобом, есть вопросы еще?
настолько мы считаем, что после дегенеративного заболевания и осложнения, когда мы удаляем диск, грыжу диска, именно в шейном отделе, мы считаем данный сегмент нестабильным и сразу проводим стабилизацию. В вашем практике как сталкиваетесь с таким проблемом? Вы тоже считаете после удаления грыжи диска нестабильным данного сегмента? Проблема стабилизации, как вы решаете тогда?
Can you repeat?
As we know, after cervical discectomy, we usually consider this segment as unstable. We presume that it will be unstable in near future. That's why we decide to stabilize this segment.
So first thing, there's studies related to it regarding the safety and regarding the concept of instability after the procedure. So the studies have shown is like 50% resection of the articular pillar doesn't affect the stability. So keep the bone resection as little as possible. If you can see the margins, if you can see the root is free, so keep the resection only up to 50%. So not more than that.
I want to clarify. He is asking about the after discectomy itself. He says that once disc is removed, the segment.
No. Like it's if you talk about the what you're talking about, stability or
instability after discectomy.
No, even after the anti-cervical approaches, when we do like for single level when we take out a lot of disc, even then it doesn't come into play most of the time.
Доктор Сантош вначале сказал, что до резекции фасеток до 50% ширины по литературным данным не вызывает нестабильности. А если вы имели в виду просто дискэктомию, то здесь в этом случае вообще в шейных эндоскопических дискэктомиях в основном фрагментэктомия, то есть тот фрагмент, который уже вышел, удаляется. В этих случаях маленькая вероятность нестабильности, но даже при дискэктомиях с передним доступом маловероятна нестабильность, по словам доктора Сантоша.
And moreover, when we are going posteriorly, we are not going right into the disc. We are just taking out the fragment which is into the canal.
I explained already.
Когда вы в лекции показали в картинках, несколько нестабильных, один был конкретно нестабильный сегмент между 4-м и 5-м, 5-м, 6-м позвоночником шейного отдела. Была картина нестабильности.
In one of the pictures which you showed on the image, MRI image, there was one image with the signs of instability, with apparent signs of instability. How do you manage this?
But on the flexion extension, it was X-ray wise, it was not that unstable. In the MRI, it was showing a little bit of collapse segment and the protrusion of the disc, but it's on X-ray it was stable.
Да, хотя на МРТ, да, была похожая картина, но когда мы проверили на функциональной рентгенографии, сгибание-разгибание, признаков нестабильности не было.
And the patient had just arm pain, no neck pain, nothing. That's it.
Да, симптоматика только радикулярная, без боли в шее. Бом саволена. Thank you, Dr. Santosh, for amazing lecture. Our next presenter, Dr. Eugen. Sorry. The topic is training program of endoscopic cervical spine surgery. How to overcome the learning curve.
Okay. Let's start. Okay. Good morning, everyone. Let's start. Okay.
Yes.
Okay. Yeah, I think I'm the last speaker, right?
No, last speaker is Dr. Bambang Darwono.
Last second. Okay, good morning, everyone, and thanks to the Woodsmiths for holding such a great meeting. And thanks for the chairman, Dr. Lin, invite me as a representative of TSES to give a talk here. I'm Dr. Eugen Lu, and I'm from Taiwan Chang'an Memorial Hospital. And my topic is very similar to Sandosh. It's about the PECD and PECF and how to overcome the learning curve. So when I start doing the endoscopic cervical spine surgery, I learned from Dr. Lin, and I think I should start from anterior approach or posterior approach. So I reviewed an article. So I found both people do it, but anterior approach, there are really limited evidence or publication related to a long-term outcome. So as you can see, there's only one randomized control trial saying the PECD, the AECD is non-inferior to ACDF as a successful rate and the revision rate. And if you review more and more articles and the meta-analysis, you think the AECD has inevitable shortcoming because it's a high demanding of the technique. And it has very narrow indication for the cases. Most of the time, you're limited to the soft disc. And for collapsed disc, posterior stenosis or calcified pathology is relatively contraindicated. So I start from the posterior, and I found I really like the posterior approach. And you know, for the cervical degenerative disease, the ACTF is still the gold standard, but the limitation is the fusion and the adjacent segment syndrome. But you will see the foraminotomy. You see this Japanese cadaver study. They found that only foraminotomy compared to the ACDF or SDF UVR or SDF with foraminotomy, it can increase the foramen the most. So only one procedure can treat the unilateral radiculopathy. And if I want to practice this posterior approach and extend my indication to not only HRVD but also the stenosis, I can easily shift from PECD, PECF to CULBD to decompress the central canal. And just like what Sandosh said, people worry about the stability. So through this Chinese Shanghai group, they do the Finney element study. They check after resect less than half of the facet using the PECD or PECF, the overall stability or overall stability under compression is even better than ACDF fusion. So you got a method that can decompress the nerve pretty well and save the stability or improve the stability. So I started to collect my cases like 4 years ago. So my surgical indication is relatively similar to the tubular foraminotomy like MIS. The absolute indication is subarticular and foraminal soft disc, foraminal stenosis, hospital like osteophyte. My relative indication is residual symptom after ACDF. You have a savage weapon to treat. Sometimes you treat ACDF, the patient still have symptoms. And you see multi-level cervical foraminal stenosis, you don't want to fuse the spine with multi-levels. Or C7T1, which is very low, you cannot approach from anterior, you are obstructed by the sternum. Or adjacent segment disease after ACDF, you don't want to do with revision wound, you go from behind. And what is the contraindication? The contraindication is you find instability, as that doctor say, you don't want to do it, so you don't want to create more instability. Or you have prior ipsilateral foraminotomy, lateral mass hypoplasia. It's difficult to dock your endoscope on the lateral mass. And we have also a randomized control, compare the PECF or PECD to ACDF by Dr. Luton in 2009. 100 cases of ACDF and 100 cases of PECF, and long-term follow-up of 2 years. The pain VAS, the arm pain VAS improvement is similar. And recurrent rate and the not satisfied rate is almost the same, less than 10%. So I'm very confident this procedure can treat most of the cervical spine symptom. So I start from 2019 February, and I collect data until last year, August. I have totally 76 cases, but in this month I have more than 100 cases already. I do 1 level, 36 cases, 2 level, 37, 3 level, 2 cases, and 4 level, 1 cases. And I do mostly C5-6, 60 cases, C6, C7, 33 cases. And this is the classic case that I have for like 60 years old female, left arm pain radiating below the elbow. So you do the MR, you see C4, 5, 6, HIVD, and C4-5 is very obvious, bulging disc on the lateral rectus. But C5-6 you see in the foramen, there's a bulging disc, but not very obvious. So I do the selected nerve blocks through the foramen to check if I need to do C5-6. I do 2 level in these cases, sliding technique. And then this is my surgical position. So initially, I do the Mayfield fixation with the head, flex the neck, as Dr. Santos said. If you flex the neck a lot for very narrow foramen, you can augment the foramen, then your instrument can go inside the foramen. But gradually, you found you don't need such a rigid fixation because it interferes your C-arm view. So you just like Dr. Lin's procedure, you use the tap to flex the neck, and you use your instrument to just a little bit pushing the IAP, and then you can have enough space for doing PCFP CD. And this is the ergonomic setup of my place. And you see my C-arm is under the spinal table, and I stand ipsilateral to the lesion site, and my camera monitor is just opposite to me, so I can be a comfortable position, like just watch my monitor, and I can do surgery for a longer time. And then the C-arm monitor is on the cranial side opposite to me. And I have two kind of approach. One is central approach, one is lateral muscle approach. Most of the time I do central approach because lamina is like 1 centimeter and the stethoscope is like around 1 centimeter. So when you push it, it's just on the lamina and the V point. And if the lesion size is far lateral, you do central approach, you can tilt your endoscope, go to more lateral. And if the lesion size on the lateral recess or central, you can do direct lateral muscle approach. You tilt it, and you go to the central, do CEULBD to decompress the spinal canal. So the amateur doctor who do the endoscope cervical spine surgery, they ask me it's very difficult to insert the obturator to the V point. As Dr. Santos just say, use the sharp 11 blade on the C-arm because the cervical spine, the muscle is more cushiated with each other. They have superficial, middle, and deep layer of the fascia. So you have to cut through all three layers. So easy for you to insert the obturator direct to the V point. And then you can start the surgery quickly. So this is my gesture. I hold my endoscope and reverse hand holding the instrument. Then the hand will not interfere with the camera. And after the surgery, I inject the steroid. And then I insert the drain because I don't want any epidural hematoma after the surgery. So let's see my video. So because it's step by step, I separate. The first is clean the soft tissue and identify the V point. And then you keep cleaning it. And then you find the IAP, SAP, and the V point. And you open the V point. And with the burr, you can clean the tissue gently. You augment this space. You clean the soft tissue. And then in one point, you found the lower margin of the yellow ligament. So from here, if you are doing radiculopathy, you don't go too centrally. You keep go along with the facet joint going out because what you want to treat is the nerve root. It's not the sac right now. And then you can see IAP and the SAP. And most of the time, it's the SAP impinge the nerve root. So the most dangerous part is how you treat the SAP. So right now, as you can see, you don't treat the yellow ligament. As Dr. Santos said, the problem here is the membrane, not the yellow ligament. The yellow ligament leaves there to protect you in case your instrument suddenly touches the spinal cord and protect you from the water pressure directly contuses the spinal cord. And then you release the membrane like this, and gradually you can, like after the final step, you reveal SAP, you can see all the nerve root. So at this time, I often do the sliding technique as Dr. Lin's teaching. So the sliding technique is easy because cervical is really close to each other. You just use one incision and the tilting to the lower level. You can do the same thing to decompress the next level. So if you want to do more advanced, you want to do PCD, you want to remove the disc. So you have to know the anatomy of the disc with the nerve roots. So what's important is C4-5. C4-5, the disc is just anterior to your nerve root. Above C4-5 is on the shoulder of your nerve root. Below C4-5 is in the axilla. So you have to remember this when you're dealing with the cervical root. So if it is on the C4-5, the disc just impinge from anterior, you have no space, and you don't want to retract the nerve root, you have to do this partial pediculotomy, partial vertebral. I think Dr. Ben described it yesterday. You remove 1/3 of the pedicle and remove partial of the vertebral body. You go under the nerve root and grasp the disc out. So I also showed the video of how I did the pediculotomy. As you can see there, I already removed 1/3 of the pedicle and the disc bulging here, pushing the nerve upward cranially. So I use the dissector, penetrate the disc. And then the disc will push out by its own intradiscal pressure. You don't need to go inside to keep grasping because it's not like lumbar. Most of the time the disc kind of hard. You just remove the part which is bulging. And then you can see the nerve root. After you decompress, it comes to the caudal side and it becomes round and less inflammation. So at this time, it's the endpoint of the decompression. So my result is pretty promising. I think everyone should try to do the endoscope spine surgery because once you see the patient's feedback, it's really immediate and good and simple. The wound is really small. One level 36 cases, two level 30, and the result vast improvement is pretty promising. And you have to always be very familiar with the anatomy of the yellow ligament. So as you can see, the yellow ligament is segmental and jumping. And what we start is from the V point. And if you circle the V point with 4 zones, there's a zone 3, there's no yellow ligament. This is a very important landmark. From here, if you treat the unilateral radiculopathy, you just go outside along the facet joint. You don't go inside to remove the yellow ligament. What's important is the membrane strangulate your nerve root. And I suggest everyone who initially do this should do the spine CT preoperatively. So this is an article reviewing the ACDF, what's the pathology label of the foraminal size. So the AP diameter is what's important for you because you go from posterior to anterior, you need to know AP diameter. So the average size of the pathology level, the AP diameter is 5.15 to 5.29. And then you see how big the nerve root is. So it's a sum of ventral root with dorsal root. So this Chinese group, the cadaver study, the root size, the sum up is 3.88 to 6.22. So with a 5.2 foramen size, with 3 to 6 millimeter nerve root, you have really less forgiving space for you to enter your instrument inside it. So it happened. So as that doctor said, post-operated upper limb palsy, if you do a lot of cases, you will see patients have upper limb palsy. Also, I agree it's a transient. Everyone is transient. But it happened. This Chinese Shanghai group, 610 cases in 4 years, and 6 cases for post-operated upper limb palsy. Mostly happen in C4-5, C5 drop shoulder. And they analyzed the CT of the foramen, and they found in these 6 cases, the foramen size is less than 3 millimeter. So if your foramen size is less than 3 millimeter, you have 66% of the postoperative upper limb palsy, the risk. So you have to be very careful. So that's why I asked Dr. Lin, he suggests you need to have this. It's a 1 mm endo punch. It's a must-have necessary. I think Max Moore has this instrument. So if you don't have it, you have other brands. I think the smallest is 1.5 with a thicker head because it's stronger. So how do you do it? You can use a different instrument. As this, when you clean all the soft tissue and you are trying to augment the V point and you remove the IAP, and what's the most dangerous is the SAP tip. Because the SAP tip just crush the nerve root. If you push instrument, it's dangerous, just crush the nerve root. You have to burn the bone as thin as this, like an eggshell, and you, along with the caudal size pedicle, insert your instrument and break your SAP tip like this. And then because it's very tight, so you use the curate to pull up your SAP tip like this. You separate because it's very adhesive. You pull up it, and then you use the angle, the grasper like this. You can remove the SAP tip away from the thick membrane. And after you remove it, suddenly you will see a lot of bleeding because it's decompression. and you stop the bleeding, you see very thick membrane like this. And then you dissect this membrane, and you will see your nerve. You can use hook or endo punch, and you will see the nerve decompress like this. Okay, so, but you always need the best instrument. So like this, the Chinese group, they have the endocusa. So it's a 33 centimeter long endocusa. So as you can see the left lower middle figure, this is Dr. Sandosh, he just described. Usually we use the retractor to protect the nerve root. You use a high-speed burr, but like this kind of case, ventral lesion usually is calcified uncovertebral joint or hypertrophy uncinate process. They impinge the nerve. Most of the time you don't need to move it, but if you really want to move it, you protect the nerve, you burr. But if it is very calcified, the burr will jump, and sometimes you hurt the nerve root. So using this kind of CUSA, you touch a nerve, it didn't hurt the nerve root. You can touch a nerve root and push it away and remove the ventral lesion safely. I think this is one of the choice. And my last topic is about the stability. What most doctors say just now, does it harm the stability? Especially when you remove the disc, you resect 50% of the facet, you worry the disc height decrease and the instability. But I want to discuss about the sliding technique, because sliding technique, when you see, if you do one level, that's easy. You do two level, you slide into the caudal side. You need to remove more IAP to enter the foramen, like the right lower figure. Does it cause the instability if you remove in the lower level more facet joint? So I check my cases. So I calculate the recesses degree. So this is A and B. So the sum of A and B, if more, is increasingly instability. So my cases, I check the C5, 6. If E represents the upper level, after the surgery, the recesses degree increased 0.26 millimeter. And if E represents the lower level, after the surgery increased to 0.33 millimeter. So there's a trend represented at the lower level. It will increase the instability, but it's not statistically significant. So my conclusion is PECF is safe and effective surgical method to treat unilateral radiculopathy. And as a start, you practice from this, you can do CU or BD in the future to decompress the spinal canal. And sliding technique is safe, and for long-term follow-up, it doesn't interfere the instability a lot. And to avoid spinal cord injury, it happened. So open the V point and preserve the ligamentum flama as a cushion in case you touch the spinal cord or your water pressure directly irrigation the spinal cord. And always tucking on the bone and thinning the bone with the instrument, with the burr, and then make it eggshell and remove it with different kind of good instrument. And I need to thanks to Dr. Lee for inspiring me doing the stethoscope procedure, and I do it a lot in the cervical spine. Thank you.
Вопросы, Саолова?
You talked about the central approach, and that I would like to know a little bit more about that.
Oh, you mean the central approach?
Yeah, central, and when you come lateral and when you go central.
Yeah. So for this, most of the time I do central approach. I just touch the spinal process, and I do the lateral C-arm view to check the disc level, and along with the spinal process, I insert the endoscope. And I tilt a little bit because the angle of the lens is 10 degrees. So I can see to the foramen.
So it's kind of inclinatory foraminotomy,
yes.
sort of?
Yes, yes.
Okay, okay.
Yes.
So that destroys facet little less as compared to,
I think like you do a lot of endoscope, cervical. I think the facet joint, most of the time, is less than 30% distortion. You cannot, you will not resect more than 50. It's difficult to resect a lot of facet joint.
Okay, okay. Thank
If, если нет вопросов, перейдем к следующему. If there is no questions, then Thank you, Dr. Yuzhen. Our next presenter, our Honorable Dr. Bambang Darwono, with the topic endoscopic technique for multilevel spine degeneration. Do we need fusion? No problem.
Good morning. First, thank you, Professor Satursunov and the committee for the invitation. My pleasure to be here. It's my 4th time here. And sorry for the late because we just arrived from the hospital, university for another. Okay. So my presentation is about endoscopic technique for multi-level spine degeneration. Do we need fusion? This is the history. Starting from Hijikata, 1970,
Okay. F, start.
Yeah, okay, thank you. Starting the history from Hijikata 1970, he introduced percutaneous discectomy and discography with small tiny instrument like this. I learned from him at 1990. Then 1980, Kambin introduced the safe zone. That's already done also by Hijikata. And in late 80s, Kreiber, Suesawa, and Liu used endoscope as discoscopy in dry condition. Then 1990, Anthony Young introduced far lateral and transforaminal under continuous irrigation. And in 2000, Sebastian Rutten from Germany introduced interlaminar and application of arthroscopic technique. So the disruptive surgical technology is from dry environment in a simple endoscopy to arthroscopic surgical dissection performed in the spine underwater with continuous irrigation and suction. 3 major steps which transfer spinal endoscopy into a disruptive technology. First, underwater dissection. Continuous irrigation will reduce intra and post-op bleeding, reduce infection rate, also significantly improve the visibility of the anatomic structures. And the range of approaches increases from pure transforaminal or posterolateral to interlaminar because rongeurs, high-speed drill, and other instruments could be used. The current indication spectrum for lumbar, thoracic, and cervical application become wide and cover all types of degenerative and other pathologies which have been domain of microsurgical technique in the past. Decompression of central and foraminal canal stenosis, decompression of lateral recess stenosis, removal all type of disc herniation including difficult case like medial disc herniation, down and up migrated disc herniation, bilateral disc herniation, calcified disc herniation, removal synovial cyst, removal epidural hematome, and also palliative decompression in metastasis. The progress of the endoscopy forward fusion technology, the MIS-TLIF, ACDF, endoscopic. For degenerative spine, where are we? Endoscope is a technically developing instrument. So the most important is how to use it for degenerative spine. The nature of illness of spine degeneration. Degeneration is a pathologic condition or damage, change the biomechanical construct in the aging spine, occur at any age, but could be prevented and be treated if we know the etiology, identified. The changes of the biomechanical construct in the lumbar spine may be single or multi-level and lead to a deformity, what we call the nymphoscoliosis. This is theory of Kirkcaldy-Willis. We know everything, and we can explained in three phases: dysfunction, instability, and stabilization in deformity. He only mentioned about the two column, the middle and the anterior column. But long time before Kirkcaldy release, 45 years, Bastrup already explained about the posterior column deformity, development of neoarthrosis between the adjacent spinous process, breakdown the interspinous ligament, characterized by abutment, enlargement, sclerosis, and bursa. But due to limited studies on histologic and radiographic changes at that time, the etiology was not well understood and his theory was forgotten in the clinical practice. But in 2010, his study was supported by Bristol study and Auckland study and published in Europe Spine Journal 2012. They studied 100 standing X-rays, 200 CT scan, 200 abdominal CT scan from age between 20 until 90. Including their orification, the lumbar spinous process getting large and wider with age. From this become like this, from this become like that. That they call the kissing spine. This is their study. L3 increase in weight from 8 mm at age 20 to 12 mm at age 80, it will increase 50%. And the height, L2 increase from 23 mm at age 20 to 27 mm at age 80, increase 30%. So if the height and weight increase, then the lordosis decrease. Now the loss of lordosis is not merely due to this degeneration, but also due to enlargement of the spinous process. This is theory of Roy Kamel. Spine biomechanical construct consists of three columns: anterior, middle, and posterior. So now we propose three-column theory of lumbar degenerative cascade. It's starting from either anterior, middle, or posterior, may suffer alone or together, from inflammatory to compressive reaction, and change the biomechanic construct of SMS, single or multi, and lead to a spine deformity, de novo scoliosis. This is a proposed new classification. Grade 1 involve only one column of three, grade 2 involve two columns, and grade 3 involve three columns. It's already published in a journal in Ukraine with Professor Azenko. The dynamic movement of the lumbar spine, knee tension band, load distribution, and sagittal balance that will be controlled by three-column natural stabilizer. That is this facet joint and ligament, ALL, PLL, and supraspinatus ligament. According to Professor Rosning, the supraspinatus ligament is not a ligament, but a multiple tendon insertion of the multifidus muscle. Now we add also muscle as the natural stabilizer of the posterior column. So this dynamic movement of the stabilizer is this facet joint, ligament, and muscle. The pathologies in degenerative spine, we call it deformer. Maybe osteophyte, hypertrophy facet lamina spinous process and canal stenosis, and also flavum infolding and hypertrophy. Now the nature of illness or deformity is combination between two factors, the stabilizer and deformer. And this will dysfunction the stabilizer and create an instability and deformity. This is the nature of deformity, combination of two factors, the stabilizer and deformer or deformator. The gold standard, open surgery decompression, but in some way will sacrifice part of the stabilizer. Then as a consequence, we need artificial stabilizer or fusion device to re-stabilize. Good result. But the question is, if we can preserve the stabilizer, do we need fusion? So concept of endoscopy for spine degeneration, retaining the stabilizer, remove deformer only, that is the first decompression. The result is we reapplied again the stabilizer and in some way will reduce the deformity. That is the second decompression. Because we believe the best decompression is deformity correction. Now this is endoscopic using arthroscopic technique, stenoscopy by Professor Lim Kamtek, and only small diameter and irrigation and suction channel in the same Advantage of endoscopy interlaminar using arthroscopy technique is docking system, closed system irrigation, wider horizon of view, retaining the stabilizer, perform decompression only by removing the deformer. We have a wider horizon from medial to lateral, right on left. This is the case. Lady 83 years old, low back pain, sciatica, and deformity like this. This is from lateral view, and this is the MRI. So we perform interlaminar endoscopic decompression only. Before after, before after, before after, and before after. Deformity correction without any fusion technique. Another case, lady 82, before. We do interlaminar endoscopic decompression. Before after, before after, before after, before after, and before after. Correction of the deformity. Because this is not a machine. In a machine like car, the screw broken, you change the screw, that's all. This is a live tissue. There is a natural healing of the body, but should be supported, and then it will correct it. And for the bone, need healing time 3 months. So in 3 months, I put in a brace and not allowed to bend and lift. Then natural healing will come. Another case, lady 55 years old, wheelchair case, claudication 10 minutes. This is the deformity. Then we perform only interlaminar endoscopic decompression, before, after, before, after, before, after, before, and after. Another case, 62, interlaminar decompression only, before, after, before, after, before, after, before, after, before, and after. We also use for cervical, 62, 3, 4, 4, 5, 5, 6. We can see how severe is the stenosis. It should be like this. Then we perform the same laminotomy or foraminotomy in this area with PSLD. We can see before, after, before, after, before, and after. This is before, no fusion device after, before, after, before, and after. Adjacent segment disease, we know a condition but that sometimes occurs after a spinal fusion surgery to join or lock 2 or more bones together and stop the natural motion of at that level. Degenerative changes develop on the disc and joint above and below the level where a previous surgery was performed. This case already operated abroad in Singapore 2012 and fusion C4567. 8 years later, come back with severe neck pain due to ASD at C4 and C71. Look here, severe stenosis. Then we perform laminotomy before, after, before, and after. Then C71 before, and after, and the day after, he smiles. So to conclude, we propose 3-column theory of lumbar degeneration. Endoscopy is a developing instrument, so the concept is how to use endoscopy for degenerative spine. The best decompression is deformity correction. So retaining the natural stabilizer, disc, facet, joint, ligament, and muscle. Remove only the deformer, osteophyte, hypertrophic facet, infolding flagellum, etc. Then it will naturally reapply the stabilizer and correct the deformity. This concept is applicable for solving the lumbar, cervical, thoracic spondylosis, either early or late cascade of spinal degeneration or other pathologies, either single or multi-level. And we already published in Tech Open publication together with Professor Rosning. Thank you very much.
Thank you, Dr. Darono, for amazing presentation. Есть ли вопросы? Questions?
So I have a question, like as the case you have shown, it was a almost grade 2 or grade 3 listhesis, and there you did just decompression. And like if we do it endoscopically and somehow the patient doesn't have the expected relief, and then he roams around and goes to other surgeons, then somebody says like he needs fusion, and why the person who did the first surgery didn't do the fusion in this case. So how to answer this thing?
Yes, this is a common question, right? The philosophy is we never treat MRI, X-ray on whatever it is. We treat the complaint of the patient and then try to find the evidence by X-ray and the MRI. If you treat MRI, you will blame everything and change it with mechanic. Yeah? This is biomechanic, not like a car. So the point is, if you can solve the problem, if we cannot make my patient younger, but make them no complaint, that is the point. But we understand the nature of illness, of the degeneration, then we understand the nature of healing of the bone. It can heal. So we should educate the patient how to support the natural healing successfully. Two patients, the same surgery, one is disturbed, one supported, the end is not the same. So who heal is not the doctors but the patient. The doctors have to show the way and do something to help.
So what's your absolute indication for fusion?
In 3 years until now, I do not use any instrument anymore.
So it's all endoscopic decompression?
That's it.
Okay, thank you.
So as a follow-up to this question, I think the education of the patient how to support the surgery becomes very important. So there are two types of surgeons, one who outsources it completely and sends to that particular department and then he has nothing to do with it. And second is ones who hires the physio in their setups and then under their observation they help them. So what is your protocol and what criteria do you use, and a little bit of information on that.
So we all know that the spine is the house of the spinal cord, right? The spinal cord itself is not any problem. The house broken and disturbed the spinal cord. That is why we need to make a complete assessment to find the evidence, which part of the house broken and how we can fix it, yes? And the good thing is this scope is very small, so we can go inside and fix everything. But that is the live tissue, not machine. Let them heal by themselves. And it's not disturb the spinal cord, it heals. Yeah. So actually I use 3 kinds of assessment. First, when I ask the patient, have a back pain, sitting or standing worse? From sit to stand worse or not? Yes. Wake up in the morning and walk in some distance pain. This MRI cannot tell you. Because MRI, you are not allowed to move, right? So we treat MRI, not treat the patient. So I do the dynamic X-ray. Then we understand why it's sometimes pain, why it's sometimes not. If you have a sciatica, that is the nerve. So I make EMG of the boot. We look at the nerve conduction velocity. Normal should be above 50 meters per second, the score. So if the nerve is normal, the score should be 51, 52 and above. Then we understand, is it coming from the nerve or not? Which nerve, how much is disturbed? If the two assessments we combine together, we have more data for the patient. If the first data and the second data telling the same, then I make MRI as a referee, the last one. Usually everyone is the first. I do the last one. If 3 telling the same, you will not wrong. because 3 people already tell the same. If we combine all 3, the same complaint will be different. Justification of treatment will be different. That is case by case. Usually make it the same. And this we educate the patient because the problem is not like infection. In infection, how severe infection is, we give the proper antibiotic, the microba died, heal. This is a mechanical problem of the spine. Then we make a complete assessment, then we understand what the mechanical problem is. And we treat that and let the natural healing. So after 3 months, I make again a dynamic X-ray, stable. That's good. Then I remove the brace and give them exercise for the muscle. This muscle is very important from neck because it's attached at the posterior part of the spine. That is why human can be standing erect. For animal, doesn't matter. Yeah.
This you do yourself, not the.
Say again.
This you do yourself. The rehab part you do yourself.
Yeah, yeah.
So, 1 moment.
Добрый день. Уважаемый профессор, вот видим, что у вас очень огромный, большой опыт. Вопрос такой, последние годы какие реоперации вы провели? И по каким причинам, если такие есть? Реоперативы.
What kind of revision cases have you performed? Revision cases. What kind of revision surgeries have you performed? Revision.
Thank you. I have a lot of cases already operated in other place. They put in implant, whatever it is, posterior or anterior. Then again, we understand that there is a ASD at the upper and lower. Sometimes we can find also in the same already operated, there is a problem there. Then we can still do with PSLD, upper and lower level, on the same level from paramedian. Not from median because there's implant over there. Yeah, then from paramedian. Just solve the evidence that causing the complaint of the patient and let them heal by themselves. So the choice for mechanical problem is only 2. One, you have a car. You want the car doing normal again, bring to the department and fix it and it's. Or, no, I still can use the car. Yes, but you know everything. Then you can prefer not getting worse. That is the choice belong to the patient. So I gave them the choice.
Большинство ревизионных операций это пациенты, которые были оперированы в других клиниках и потом обратились в эту клинику после фиксации fusion. То есть это пациенты с болезнью смежного сегмента, когда сегмент выше и ниже фиксации дегенерированы и беспокоит пациента. Это в основном были эти пациенты, их можно легко лечить с помощью, то есть оперировать с помощью PSLD. Да, высший сегмент или нижний сегмент, или в том же сегменте есть фораминальный стеноз с парамедиальным доступом. Еще вопросы, сауалlar bormi, hamkasblar? Thank you.
Thank you.
Thank you very much for a great presentation. Hurmatli hamkasblar, hozir bo'lmasa coffee break. Keyin ungacha operatsiyalar translyatsiyasi boshlanib qoladi, xudo xohlasa. Bo'lmasa birpas dam olaylik 15 minut.
hozir bunga qanaqa qilganda qilaman? Shumi? Men hozir bir ikkita slaydlarni tashib olmoqchiman.
Tashib olish kerak, shu yerga mana.
Ha, buni.
Уже в принципе на связи. Просто да, они картинка туда идет, и звук, все есть.
괜히 옷을 빨리 입었네. 기다려야 되네. 응? No? No audience.
I think it's okay.
Should I start?
Yeah, just it's now I think conference room is empty.
지금 바로 연락 들었어요. 지금 다들 들어가게.
And 5 minutes.
Just tell them we're ready.
It's RF. It's drill. Why? Oh, it's okay. It's drill. I will check. It's drill. No, drill. Only the yellow. This one. Oh. Oh. Oh, what? Yellow. Can I use your food?
Yeah.
Yeah, because food is better.
Yeah, food is better.
Okay, I will.
No.
Oh.
No, other one will change. You can stop.
I think it will be fine during the operation without the water. Right? Yes, they are coming. The first check, please. Where is Shyam? There. Shyam check. Going down. 4-5 first. Same check. What is? What is up and down? Okay. Same check. Same. It's 4-5, right? Thank you. Wait. Hello? Hello, Dr. Shamansura, can you hear me? Hello? Hello, can you hear me?
Hello, Dr. Lim, can you hear me?
Yes.
Yeah, we're about to start. I asked the delegates to join the group. They went for the coffee break, but in 5 minutes they will be in the audience. So 5 minutes.
Okay. 5 minutes. The first case, right. I will perform the 2-level, decompression, 2-level decompression. How is the?
Can we see the MRI of the patient? Can we see the MRI?
Okay, MRI. Dr. Ijam will explain the MRI. Okay. The patient have L3445, the lateral stenosis. So the patient has the body tropism. So left side, the lamina is more the wider. So I'll try to left side approach, contralateral decompression. First, I'll start L45 and then jumping up to L34 with one skin port. How is the body weight? The patient body weight? 100, more than 100, right?
Yeah, we can see them, all right?
Yeah.
So the 2-level, huh? So you do bilateral decompression. Yeah.
Yeah.
From one skin incision,
So
I think.
How was the symptom? Symptom was the claudication. And first, I will approach the left side, it's we can feel the spinous process. That's why we don't need to check the AP view.
Demek
So
benim orada
with only the
iki urinde
lateral view, we
stenos,
can
iki urinde stenos,
the landing
L4,
endoscope
L5,
system and the left
L3,
side.
L4. İkkalasini dekompressiya qilaman deyaptilar, bilateralniy dekompressiya.
So skin incision should be the just beside the spinous process.
Aman chaqirish kerak-da. Tashqaridagina chaqirish kerak, kirish kerak. Dr. Lim, you can start with, we are ready. Everybody is watching.
Okay.
Ovoz uzilib qoldi bola. Qani IT bo'ldi? Ovoz кажется, звук оборвался. Сюда не доходит, он что-то говорит. Там вот же, ничего не слышно же. Есть что-то?
Okay. So we can feel the midline, the spinous process, and just beside the spinous process. So Shyam, check again. Shyam. It's L45, the first skin hour. The mosquito. So I can feel the spinous process, and just beside spinous process is a landing point. The sham check. Right?
Руками просто чувствует остистый отросток и рядом с остистым отростком просто делает доступ.
Sham check. Okay.
И глубину он проверяет с яром.
Water open. Okay.
Easy.
So the faucet turn off, please. Turn right. Okay. And the first we have to find the lamina and the spinolaminar junction. It's lamina, right? Lamina. And 12 o'clock is spinous process. Bipolar, please.
В 12 часов это остистый отросток у него. В первую очередь, что он ищет, это spinolaminar junction, то есть место прохождения остистого отростка в ламину.
It's not working. It's not working. Okay. First, right? It's a spinolaminar junction, right? Lamina and the 12 o'clock is spinous process. Punch 2.
В 12 часов остистый отросток.
Right. Huh? First, we have to expose the ligament flavum. We have to reach to uppermost ligament flavum. 자, drill. Yellow. It's not working. Okay. This third system is the shaver. So, if you the right side of the fourth finger will act as a stopper, right? Do not use the drill like this, dangerous, right? Punch, 2. As 4 millimeter punch, reverse.
Билатерально, потом 3-4 билатерально.
Okay. Bipolar.
Şimdi savol, у кого есть вопросы, можете задавать. Я буду задавать доктору Мулиму напрямую.
It's not working. Not working. Okay. You can see inside the ligand flavor, drill. I need to more bone work. Okay, 4 millimeter punch, reverse. Okay. Yes. L4, 4-5. What? Oh, no, it's okay.
YouTube'ga ketyapti. YouTube'da hamma saqlanib saqlayapti. Kan ko'rsam bo'lasiz.
Okay. So almost uppermost ligament flavum, right?
Да, он уже
How is it?
место подкрепления этого желтой связки уже определяется. Сейчас он до места
So
подкрепления
when
желтой
we
связки
started,
дойдет, потом оттуда.
check the time, operator time. Operator time. Okay. It's the uppermost ligament flavum, right?
Yeah, we
Right?
can see,
And
Dr.
then-
Lim. Yes, we see.
Okay, and then we can insert the sponge and turn the endoscope, right? To see the under the ligament flavum to know the damage of a dura. It's okay, right? Right? It's okay. And then we can remove. Okay, 3. So I need more bone work. It's a caudal part.
Уже латеральный чуть пьет, латеральный начал. Нижний двигательность, видите? IAP.
Bipolar. The 4mm punch, reverse.
Нет, это корейский электрод. Окей, медийный.
It's lateral margin. Right. IAP. Right. The first, we need to expose the lateral margin. The first step, to remove the fat tissue. After not enough. 자, 4mm reverse. The MRI shows not severe, but actually inside the narrow space. Drill. Okay, 4mm carries reverse. It's a lateral margin, overload. It's a pedicle area. It's a L fiber of lamina. And then ipsilateral decompression has complete. So I'll move to the contralateral side. Forceps. Dissector. It's done. It's discal space, annulus. Okay, that's pedicle area. Decompression enough. Okay. proof, hook. Some fibrosis. Faucet. It's not working. Bipolar. Bipolar. Okay. Punch. 4. Okay. Then move to the contralateral side. Drill. So usually for the ipsilateral decompression, it takes over time is 10 minutes ipsilateral. Bipolar. 자, drill again. Drill. In my operation room, I teach the young surgeon the way how to complete operation, one level bilateral decompression, less than 30 minutes. 자, 4mm punch, forward. Faucet. Do we have another one? Faucet? Faucet? Bigger? Faucet? Okay. Bipolar. bipolar. Oh, it's okay. It's a mic. Huh? Headphone is okay. Oh, my. Oh, it's not working. It's not working. Punchy, it's not working. Okay. Huh? It's not working. 2 millimeter punchy, forward. It's contralateral, ligament flavum. Is working? Okay. Bipolar. Okay. 4 millimeter. 4 punch.
Самый нормальный. Он 22 тысячи. Что хорошо, но сокет не такой ежик, да, а этот обычными полями, которые рисуются, там молотки мало. Специально свой абилятор, то есть свою насадку не обязательно покупать. Любой можно молотки, то есть которые и все. Ну да. Изображение оттуда же исходник берется, поэтому он не такой, а такой лучше показывает. Это похоже. Да. 20, что ли, 20, да, вот так стоит. Если у кого-то есть вопросы, доктор Лин, можно онлайн задать, проблем нет. Если вопросы возникнут из аудитории, savol bo'lsa, marhamat bemalol.
Okay, bipolar. 4. 4 millimeter punch, forward. Okay. Process. 자, 4 mm punch, forward. SAP, contralateral side SAP.
Это да, эндоскопия.
Lateral margin, but we need more the bone work. Drill, not enough. Drill. 자, 바이폴라. 음. 4mm punch. Forward. Okay. Force. You can see lateral margin. Punch, 4mm punch, forward. Okay. Two millimeter punch. SAP. Yes. Okay, 3. Oh, sorry. Okay, 4. Reverse. Okay, we have a final destination. Almost there. Force. Force. Uh, 2mm punch forward. 괜찮아요. 네. SAP.
Yes, Ahla, we are hearing you. Yes, you can speak.
Okay. It's final step. It's a pedicle area. Okay. The force. Dissector. That's lateral margin. It's contract side disc space, right? Annulus, right? It's pedicle area. You can see the root. Shoulder, force. process, the finish, it's not working. Not working well. Oh, it's not working. Another one.
He broke the forceps.
Okay, dissector.
Very expensive forceps.
Okay. It's a shoulder, the pedicle area. It's okay. It's extra portion here. Punch two. It's an extra portion. Okay. Faucet. So one level takes 20 minutes. Okay. Okay. Dissector. You can see it's an axilla portion here, axilla, right? And the shoulder, and ipsilateral also, right? It's a discal space. It's an axilla portion here, axilla, shoulder. Okay? Okay? Finish. Okay? And then I'm going to move to the 34 mosquito.
Dr. Lim, can you show us the MRI again? We want to see the MRI for 3-4.
And then 3-4 mosquito. The jumping up mosquito.
Yes,
turn on please. Turn on light. Okay, jumping up like this.
Yes. L4-5 also, which was done just now.
Jump check.
This is 3-4, which will start now.
No.
And 4-5 also. Can we see the 4-5 also?
Camera here. Okay.
Just zoom out a little bit.
Here. So jumping up.
Was finished.
Right. Okay. It's a 4-5, right? I'm going to jumping up. Sham.
Can we see the C-arm, please, also? Can you show us the C-arm?
Okay, 3-4, right? Obturate again. Sham. It's a 3-4, jumping up. Okay. There. Again, water. I will start L34, faucet. The same way. Bipolar. It's not working. It's not working. Okay. Okay. Faucet. Bipolar. Oh, it's not working. Nice. Why? It's not working. Bipolar. Is it working? It's not working. Huh? It's not working. Just only sound, not working. Okay, it's okay. Okay. Working good. Working on and off. It's a spinal laminar junction. Punch. 2. Reverse. It's a spinal laminar junction. Three. Bipolar. Near 자, 2mm punch, reverse. Right. I don't need. I don't need. It's yours. Strong bone. Right. So killing me my arm. Killing me my arm. The bipolar. And drill. To reduce the operation time, the drill should be up and down, right? bipolar. Okay, 4mm punch, reverse. Oh, so narrow. Yes, 2mm. 2. Reverse. What? Reciter. Recital. Do I need to sing a song? Okay. Okay. 34. It's cranial L3 lamina. The 4mm punch, 4 reverse. Okay, we have arrival, uppermost ligament flavum. Okay, drill. Contralateral side to make a space. The 34 is very narrow, the spinal canal space. So bipolar, there is no room to handle the instrument. Oh, sorry. Is it okay? Okay. There are 2 punch forward. First, remove. Forceps. 1. 3. Four millimeter punch, 4 reverse. Always the bone work, there should be as much as we need. Forceps. Okay. Severe narrow space, narrow. I cannot find the space. What happened? 4 millimeter punch. Oh. Forceps. Bipolar. Drill. Okay. It's a bone bleeding, 2 millimeter punch. Bone bleeding, our control. It's like this. Compress. Right? Like this. Right? Stop the bleeding, right? Bone bleeding. It's usually the cancerous bone.
Gupçti suyedi. Çünkü almazlı bir bulan uzganda to'xtan oldi. Gupçti suyeni ezsa bo'ladi. Eziluvchi bilan prosta ezib qonni to'xtatib qo'yadi.
Wow. 4 millimeter reverse. bipolar, civil narrow space. The process. Bipolar, bipolar. Drill. Four, punch, reverse. Four set. Wow, too narrow. Yes, Jura. 4 millimeters punch, 4 reverse. And the contralateral side. Just should be careful. It's a midline folding. There is no taco shell in Uzbekistan, right?
Yeah, we hear the Dr. Lim's comment. It's truly like this. We don't have tahosil.
2, 3, 2 more. Whoa. Oh, he's okay? Oh, bipolar? Okay. Two punch forward. No, 3. Bipolar. Oh, it's not working. Why? 2 minute punch. 2 forward.
Там вот такая трубка, сейчас я вам покажу. Это F18.
Bipolar.
Чуть меньше, да.
It's working? Okay.
Одна просветная, но этот, там
Okay, 2 punch, 2 milli punch forward.
фенестрированный, да, сейчас я вам покажу.
Force. Force.
Вот такой он примерно. Вот такой. А тут такой шланг должен быть.
Two punch.
Вот такой, вот такой, вот такой.
Forward.
Вот такой. Там есть, кстати, у спонсоров они показывали. Здесь есть. Это он сгибается, и может согнуться, и не будет работать просто.
Contralateral.
Режим коагуляции для резания не используют. И не надо, зачем, куда, что он будет резать.
Wow. Wow. 3, 4.
Компрессия 3-4 литра. А обычная грыжа 2 литра хватает. Ипсилатуральный реконструкция 2 литра. Сейчас, наверное, уже до 4 литров. Нет? Играете? Ничего сделать. Я делал, но немного. Минут 10-10.
Forward. 4 millimeter. 4 punch.
Показывайте. Алмазный. Можно просто зажать вот это. Это хороший апеллятор, если есть, можно его использовать.
Upper lamina L4.
Только слишком долго нельзя закрывать отток. Давление над ламиной очень большое.
Process.
На помпе
Process.
отток сильно на долгое время не надо закрывать. Ну, если это подсознание, шея начинает болеть, да? Если под общую наркозом,
Two punch.
очень высокая, если
Forward.
то этот судорога может.
S lateral margin over root. SAP. So after resection of SAP, the bleeding means decompression is enough.
Это надо. Это очень удобно. Нет, это с завода надо заказывать. Специальный упаковки.
SAP. The MRI shows the mild the stenosis spot, actually, the severe. Lateral recess. 3 more. Four punch forward. There's a 2 punch. It's okay. Better. What's that? Bipolar. Okay, forceps. Okay, dissector. Okay, so lateral margin. Quadrilateral. Right. Yes. Okay, it's annulus. It's lateral margin, right? Forceps. Forceps. Lateral margin. Dissector. Okay, you can see lateral margin, right? It's lateral margin. Punch forward, 2. Forward. Okay, enough. And then confirm the ipsilateral. Okay, 4 millimeter punch, reverse. Ipsilateral. Confirm dissector. In narrow space, you should be careful not to damage your fascia joint. It's a lateral margin, right? You should be careful. Right. 4 millimeter. Dissector.
Dr. Lim, can we see the irrigation water that we use in natural flow? Can operator show us how the irrigation water is staying? Little bit higher. Oh yeah. Thank you very much.
Okay, 4. Punch, reverse.
Я вам скажу, где-то 2,5 метра. Да.
Dissector.
Давление hech narsa boshqarmaydi. Demak самая кислота.
More. Drill. should be careful. Do not damage the facet joint, narrow space. Four punch, reverse.
Yeah, but can you speak a little bit higher because we don't hear you well, but something we can hear, yes.
Yes, almost. Dissector.
We can hear you well. We don't understand what you're speaking. We can hear you well.
Okay, it's lateral margin. Open. Okay. Okay. Forceps.
Can you show us the CRM,
okay.
please?
No more. No more. Because it's narrow space. It will happen the facet, the damage. Yeah. That's okay. Finish.
Yeah. Yeah. Thank you. Thank you.
Okay. Let's. Forceps.
Dr. Lim, can you show us on the CRM from which point?
What? Oh, yeah.
Yeah, can you show us on the CRM from which point up to?
Okay. So 1 second, please. It's bleeding. What? It's bone bleeding, right? Bone bleeding. Bone bleeding. Okay. 2 punch. Our reverse. In case of bone bleeding, you can use punch. Compress. Okay. Call the family. Okay. You finish all. Expose the lateral margin infiltrates already, but no more bone work because it happened facet damage. Okay, this is lateral margin bipolar. Okay. Forceps. Okay, lateral margin. Finish all.
Yeah, Dr. Lim, can you show us on the CRM from in the sagittal view the decompression point from highest and the lowest the decompression level?
Okay. Sham check. Sham. Right. It's upper. Right.
Yeah, it's upper point.
Can you see?
Yeah, we can see but a little bit. Yeah. Now we can see. No. Can you show us the CRM? Yeah. We can see now.
Okay, Siam, okay. Upper and the lower part. Siam. Right?
Yeah. Now we
It's
can
okay?
see. Yeah, it's okay. Thank you. Thank you very much. Yeah.
It's L4 upper lamina and L3 lamina, right? It's contralateral lateral margin and the ipsilateral margin, right?
Dr. Lim, wait. Can you show us the ipsilateral, the root, the axilla and the shoulder of the ipsilateral, the root?
No,
which you
L34, in L34, root is lower. It's the typical fiber, check the L5 root is easy, but usually L34, 4 root is more than the low portion, so.
Okay, yeah. We got it, yeah, thank you.
Он говорит, слишком низко отходит.
What's that? At L34, to find the L4 root is difficult because located the lower than the L4 lamina. What's it? It's the contralateral side. Okay, I'm waiting for the family dissector. It's a low portion of discal space, but not easy to find the root or L34, right? It's lateral margin. But you can see the pedicle area decompression enough. Also here. Families are coming. 설명 좀 해주세요. 신경.
Пульсацию показывает, как это пульсирует дурально, обратите внимание.
Okay, drill.
Doktор Лим это привычка доктора Лима, он вызывает в операционную родственных больных и показывает конференцию, как бы, чтобы вопросов не было. Скорее то же самое делает.
Okay. 4 millimeter punch, 4 reverse. Drill. Okay. Punch 4. Okay, SAP. Mm-hmm. Okay. Dissector. It's a lateral march. But should be careful not to damage of its lateral margin, not to damage of the facet joint. Okay? It's okay. Oh well, bleeding. Okay. Okay, I'll finish. Well, bone bleeding. Yeah, this one, same. Eh? The 4, bipolar. It's always to control the bleeding. Eh? So we have to the mind. I know who you are. Eh? I'll find you. I'll kill you. Right? Where you are, I'll kill you. Right? Kill you. Okay? Oh, it's okay. Kill. Okay. Anyway, it's okay. Okay. Dissector. Okay. The finish roll. But okay. Lateral march. It's enough because I don't want to more because you have a chance of the facet joint damage. It's okay. Okay.
После вашего вопроса решил так.
Okay, and turn on, please. And I will keep the drain to drain. Usually the one level bilateral decompression, that should be the less than 20 minutes. But today, here the drill function was not good. But anyway, the one level, the 30 minutes is as good. If you do not 45 minutes. Okay. If you do not finish operation the 1 hour, so in case of a 3 level, it will take 3 hours. It's impossible. We got too tired. So in my operation room, always I teach the young surgeon how to finish it operation the less than 30 minutes, one level. 맞나? 왜 이렇게 굵어? Too big. Right? The 시험 check. 시험. Oh, it's invisible. What? Is this small? Do you have a small? No, one more. Obsolete. And L45. Oh. Samson? Samson?
It's too big drain. 시험 check. No problem. There was a small drain before. 시험 check. 시험. 시험. 시험. Okay. Walking sleep. 시험 check. 시험. 시험. 시험. 시험. 시험. Drain one. You have to change it. This drain too big. 시험. Okay, to drain. Gosh. Okay, tie. 빠졌다. Okay. Wow, it's too big, thick the drain, so it's not easy to insert. 시험 check. 시험. 시험. 아유. 시험. It's too thick the tray. 시험 check. 시험. Okay. 시험. Oh. Wow. 시험. 시험. 시험. 시험. Okay. The tie. Okay. Okay. Any question? Any question? So with one scan port, we can do 3 level.
Garmoshkasi bor. Garmoshka gulab negative pressure berib qo'yadi. Ya'ni отрицательный давление berib qo'yadi. Garmoshka gulab.
Вопросов нет? Savollar bormi hamkasblar?
Dr. Shomansuru, do you have?
Yes, we can
any
hear you.
question?
Any question from audience? Savollar? Yeah, the no questions, Dr. Lim. Everything is great.
Okay.
Thank you.
In
Thank
Korea,
you very much.
Yeah, in Korea, we have only the two the category the spine society. The one is the endoscopic society, and another one is a deformity. And the microscope, we don't use microscope anymore now. From the C12 and until the ACDF, posterior cervical decompression, and thoracic, the lumbar and the lumbar fusion decompression, all pathology, we can use the endoscope surgery, except the deformity. So in the near future, all spine society will be changed. The trend of the spine operation will be changed to endoscopy.
Yeah, thank you.
Thank
you for your comment, Dr. Lim.
Okay, thank you. And the next case is L45 severe stenosis, the 1 level.
Can you see the MRI of next patient?
Next patient. Okay. compression, and then for the Время, I practice the decompression control lateral approach. Right? So again, for left approach, bilateral compression, and for L4 compression, apply to contralateral the parameter.
Hello, Dr. Ahror. Yes, I'm here. I'm Dr. Kandimov.
Can you hear me?
Yes, we can hear, but audience is went to for the coffee break. They will be back in 10 minutes, I think. In 10-15 minutes.
Yes, I draw what's the approach.
Yes. Mm.
Okay, then delegates come back, let me know, okay?
Yes, I will let you know when delegates will come back. This contralateral approach.
Transmitter, break, finish.
Where it breaks? From which side? From there or from our side?
Don't know. I think she can help. Event.
А где наши техники? Да, потом почему-то связь прервалась. Отсюда или оттуда? Они выключили? Yo'q, bular bu yoqni anaqasi. Xodim, biza o'zimiz orzu, tanisiz-ku.
Orzu, ha.
Chochlaydigan.
Foydali.
Ha?
Qancha o'ttiz aytyapsiz? Orzuda.
Sizlarnikini o'zim olib borarman-chi bo'lmasa.
Biz ketaveramiz. 4 kishida biz.
4-chi kim?
Aziz.
Aziz. Zafar. Bular Pushtakan. Bularning familiyalarini yozdiruvmidingiz? Chunki menga siz 3 ta familiya beruvdingiz.
Yozdirmadim Pushtakan.
Yozishni men bilmadim-ku. Sizni Zafari Aziz yozdirgan. Chunki ular bergansiz.
Pushtakan qo'shilsin.
Boshdan yozilganligiga tayyorlagan. O'xshasa kerak, so'rab yetarli ko'rma.
Biz shunaqa qilay bo'lmasa bizda shanba ertalab borib ertalab vaqtingiz bormi? Hozir kelish kerak. Reviziyaga pul o'tkazaman deyapti. Paramin ishga chiqdi. Paramin kichkina endi ishga chiqdi. Sheviram kelish kerak. Bugun Sheviram kelish kerak. İcaraga içime açıldı. Başkalar götürmememizde. İlk baktım. 7.700 davalanış. Yaşlılar. Bizde tamamen pulum yok. Tamamen de diye. Zaten keşif etamiz. Sizler hafif parayla çıktı. Hemen istiyoruz.
qilinmagan bo'lsa, в принципе, qiyin bo'lmasi kerak. Ну, anaqa spaykalar yo'q hisobda. 4-5 minut. 4-5. Paris qaysi anaqada qilyapti? Qaysi gruppada Paris? 4-5 da foraminani bo'lsa, u qayerda og'riq qayerda o'zi?
Og'riq mana bu batta kuchli og'riq. Boldir sohasi.
Chunki 4-5 foraminda bo'lsa, 54 karishok oldida bo'ladi. Bu yoq bo'lsa, demak 55 karishok kanal ichida problema foraminda bo'lsa. Hozir bir 5 minut kutaylik. Agar Shomansur anaqa hozir emas, keyin desa o'tirib turasizlar. Tushunmadim. Ikkinchidan keyin ketasizlar, a? Qatarga sizlar kimni bilasizlar?
Sherigimiz. Ha,
Salom.
Qo'yam qo'lini tutib turibdi. Zoring qo'yib hozir qo'ygan fayndan. Tayyor.
Siz tushungan, Toshkentda o'qiyapsiz, Andijonda o'qiyapsiz. Andijonliklar o'zidan kattalarni ham sansirab yuribdi. O'zi olib boradi.
Bizlar o'rar ekan deydi.
Shu zal yaqinroq, 50% yaqinlashdi.
часа, да, ночью, да, звонит, отключаю, звонит.
Я не смотрел просто, вот так отключал, думаю, пациент. Что, где, когда будет? Не знаю. А это кто? Рядом какой-то. Он никак.
Qarashiga ketdik. Aytdik. Ketdik.
Спасибо. Ждем следующую конференцию с докладом. Я знаю, я же вас слушал, все 10 докладов слушал.
Numaram ochib olishimga telefon numaram. Bitta nomer qo'shib yozib oling. Bo'p. Одноразовый вот взяли доллар. Был многоразовый. Muhammad, sizlar vaqt yuribsizlar, o'tib kelinglar, chunki men videoda ko'rib qoldim. Aziz vaqt borib olyapti. Bo'ldi. Menga qara, u qachon kelasizlar bu yoqqa? Azizchi, Aziz. Yo'q, Rossiyaga gaplashmoqchi edim. Mayli, agar operatsiya bo'lsa qo'shsin. Keyin menga qara, hozir anaqani so'rab ber. Keyingi operatsiya fusionmi yo nima operatsiya bo'ladi, nimaga bo'ladi. Возможно, просто рекомпрессия. Hello? Ahror? Oybek? Oybek sanmi? Bu nima operatsiya bo'ladigan bo'lyapti u yoqda? Yo, dekompressiyami yo fusion bo'ladimi?
Tlif qiladimi? Tlif? Yo, ana vint qo'yadimi, yo'qmi? У нас обычно возникает, когда завозишь. Там, чемодане на 10 лет куда-то. Здесь ты понимаешь, за одно ничего не стоит. Ладно, ты надо будет так. У нас нет. Есть свойства. Это уже. Ну, смотрите, есть. Идемте, будут посмотрим, я вам кое-что сейчас покажу. Вы хотите дать? Давайте попробуем. Сейчас это вам я буду покажу.
Поехали, все, спасибо большое.
baland. Kasal уже tayyormi? 10-15 minutda boshlanadi. Bo'ldi, shuni telefon qilamiz, qanchada boshlanadi. Ovozni keyin ozgina to'g'rilab olsanglar, tak yaqin.
Hello, Dr. Lim, Ahdal, are you there?
Hello. Hello.
Yes,
Dr.
yes.
Kandimov, can you hear me?
Yes, yes.
Dr. Shamasar, can you hear me?
We both can hear you.
Okay. Our next case is 4-5 severe canal stenosis. Patient has back pain.
Only back or neurogenic claudication also?
No, back pain only. Back pain. We can see it on the MRI also. Each level is already diffused. And our approach is on the left side because can you see is 4-5 on the right side. There is foraminal stenosis also. That's why the approach on the left side. Approach we can do first bilateral decompression. Bilateral decompression and second foraminal decompression is over the top technique. Foraminal decompression Dr. Lamy is planning.
Yes.
Pictures is clear?
Yes, it's clear. Back pain, both sides equal, left and right, or one side is more dominant pain? I think the instrument.
White balance is not good.
Exit tagida yozilgan.
Yana pastga bosing.
Now working.
Hilola pastga bosing. O'tib ketib qoldingiz. Bitta tepaga. Bitta tepaga.
White balance.
Mashallah.
Bo'ldi. O'rtani bosgan, o'rta knopkani bossa bo'ldi. Yo'q, oqqa qaratib turib bos, bo'lmadi white balance.
Uchiga tegizdiring-da, polni to'silsin uchi oq salfetkani. Da, oy, mana shunaqa.
exit chiqib ketish kerak, bu yerda qilinmaydi. Boshqa joyga kirib ket, exit qilish kerak. Chiroqni kuchini ko'paytirish kerak, axir dark dot. Light source anaqasini ochgan, ko'proq. Balandroq ko'targan. Keyin haligini uzgunda anaqadan, skopdan light source kabelni uzib turib, ko'rsatib turib, keyin qilgan oladi shunda. Da, shuna qo'yib turib qilgan qiladi shunda. Da, endi qilsam bo'ladi white balance.
Hello, can you hear me? Can you hear me?
Yeah, yes, Dr. Lim, we can hear you.
Okay. The white balance is not working.
Axir, oq salfetkaga emas, boshqa anaqaga ham qilib ko'rgan tsvetga, liba ko'k rangami, boshqa tsvetga ham qilib ko'rgan.
Okay. It's such a different system. Okay, finally, the corrective, the white balance. Okay, I will start. Okay. Straight. It's a mid-line. Where is Sham? Sham check. 4-5. Sham check. No more. Sham check. Okay. Yes. Just beside the spinous process. Mosquito.
Yarim monitorni sal kamera tarafga burib qo'yish iloji bormi? Oybek. Bo'ldi, rahmat. Bo'ldi, rahmat.
Sham check. Okay. Oh. The process. It's 9 o'clock. Is the cranial. Oh, bipolar swirls. How is it temperature? Temperature of RF? Okay, it's a spinal lamina junction. Okay. Yeah. Punch, 2, reverse. Wow. Bipolar. Okay. Punch, 2. Wow. Forceps. Okay. Punch. Two. Spinal laminar junction. Jump check. Jump. Okay. Drill.
See arm picture, please.
Bipolar. Okay, drill. Very strong bone, and too thick the lamina. It will take a long time. To approach the contralateral side, I have to perform the bone work too much. The lamina and the cerebrospinosa bone. Bipolar. Okay. Drill. Bipolar. after fascia joint, mountain, and around the mountain, the hypervascularity. So you can expect Chunga mountain. You can expect bleeding sometimes. It's a spinal canal. Wow. Okay, three. And too strong bone. It's very hard. 자, 2mm punch, reverse. Punch, reverse. Oh, no, it's the water. Oh, my leg is wet. Punch forward. You have to the whoa, the water. Oh, no. My leg. Oh, sorry. Wow, my. Whoa, why? Okay. Yeah. Okay, it's okay. Drill. It's a spinous process. To reach to contralateral side foramen, we have to drill more here. Sham check. Sham. Sham, not working. Sham again, not working. Oh, okay. Sham again. It's not true lateral. It's not true lateral. Sham. Okay. Pass. Okay. 2 millimeter punch forward. It's 2, it's 4. Forward. Okay, so almost uppermost ligament fiber. Okay. Drill. Drill. Well. The four punch reverse. Okay, drill. Okay, the 4 punch reverse. 4. Okay. Okay, the uppermost ligament flavor, and then we can insert our punch under the ligament flavor, and then we can turn endoscope. You can see the under the ligament flavor is okay, right? No damage of dura. We can take away. forceps. We have to remove fat tissue to exposure of dura. Too much fetish, right? Punch 4, reverse. Okay, you can see the dura inside the ipsilateral. Okay. Okay, drill. Oh. Bipolar. Okay. 4 punch, 4 reverse. Drill. More. Need more bone work. So sometimes I think the endoscope surgeon is not doctor, labeler, right? Punch 4. Okay. So ipsilateral decompression. Okay. Lateral recess. Okay, forceps. Oh, wow, you can see dura? Eh? I bite the dura. right? Who should be careful, right? It's okay. It's okay. It's your patient, right? Drill. Okay. Bipolar. Bipolar. Oh, sorry. Punch. 4. Reverse. Okay. It's lateral margin. Forceps. Forceps. Dissector. It's lateral margin and annulus. Annulus. 4 punch. Reverse. Drill. Drill. Punch. 4. Forceps. Punch. 4. That's true. 4. Bipolar. proof, proof, hook. You can find the lateral margin here, right? And then forceps. Oh, sorry. Punch. 4. Reverse. Two punch. Pedicle area. It's axilla, I think. Drill. I need more drill. Wow. Upper lamina. Okay. Oh, two punch, reverse. Oh, too short. Drill. Okay. 2 millimeter punch, reverse. Wow, too strong bone. Drill. Drill 주세요. Okay. The four punch, reverse. Okay. Yeah, but ipsilateral is incomplete. I will check again to make a space first. Almost done, but dissector. It's lateral margin, right? It's lateral. It's axilla here. Axilla portion. 4 millimeter punch reverse. Okay. Faucet. Okay, it's axilla. Okay, can you see axilla portion? Dissector. The pedicle area, shoulder, there's axilla, axilla. Okay, and then drill, contralateral side. Okay. Punch two forward. Faucet. Okay, drill. Right under the spinous process to reach the foramen. Bipolar. drill. Wow, so hot. Drill. Faucet. Drill. Okay, 2 millimeter punch, forward, 2 millimeter, two punch, okay. Okay. Faucet. Bipolar. Okay, punch, 2, forward. Hey. Punch, 2, forward. It's a contralateral ligament. Thick ligament flavum. Oh, I don't need. I don't need this one. Okay. And then faucet. Okay. Bipolar. Sometimes I like the shrinkage Jura with RF to see the more detail, the contralateral side. Shrinkage Jura. Okay, better than, right? Punch, 2. and there is space here. So our faucet. Okay, punch immediately forward to. Okay. SAP, contralateral side. Process. Okay, 4mm punch, reverse. Then two punch forward. Okay, drill. Wow. Right. Okay. Punch two forward. Wow. 와, 들을 와, severe. Okay, 2 punch forward. Okay. The aging society, there are so many cases of the stenosis. Not the very rare, but very rare the disc. Wow. Huh? Other agent? Force? Okay, it's SAP. After remove this, we can find the L4 root. Punch 2 forward. Wow.
Dr. Lim, the removing parts, is it the disc parts you're removing, or it's just adhesions?
You're gonna flavor calcified. Wow. And this is the SAP, contract SAP, and almost, okay. Calcified. Wow. Okay, drill. Okay, 2 punch. Well, it's calcified, right? It calcified this. I calcified the ligand flavor. This. Wow. Bipolar. And dissector. Yes, I have to remove this calcified the ligand flavor. Right? Okay. Punch 2 reverse. Wow. All calcified. Okay. So here you can find the L4 root, action root. Well, it's calcified, right? It's a foramen. It's foramen. Yeah. You can see L4 action root here. Wow. The hook proof. It's a foramen. Wow. Calcified all. Okay, 3. Wow. Okay, punch 2, reverse. IAP, it's SAP, it's a SAP. And this is a calcified ligand flavor. Okay. SAP. Bipolar. Punch, reverse. Oh, forceps. Okay, drill. punch, reverse. Su. Force. Force. No spaces, so I try to. 요거. drill. Punch, 2, forward. Okay, it's a root pedicle area. Traversing. Okay. Okay. Okay. Okay. It's SAP. Hypertrophy. Drill. Okay. Force. Punch 2, forward. Okay. Wow. Osh. Force. dissector. Okay, punch, reverse. Drill. Two punch forward. It's pedicle. Absolute. It's annulus. Okay, well, so finally, it's calcified annulus, this one. Wow. Oh, come on. Pause it. Okay. Punch 2, forward. Okay. What's it? Too big. Punch. Okay, bipolar. Oh, still calcified. After remove this, we can find the L4 root. Okay, proof, hook, hook. Okay, punch, reverse. 2. Oh, 2. Punch. Okay. Okay. Wow, too big. Inside you can see L4 root, bipolar. It's L4 root. Oh, sorry. It's L4 root. Punch, reverse. 2. And the axilla portion here, axilla. drill. Okay, punch, forward, 2. H root, H forward, this, yeah, this L forward. Oh. No. It's remove the flavor. You have to remove this. You can find L forward. Okay, so for A1. Oh, still. Okay, punch, 2, forward. It's for A1. process.
Dr. Lim, the part you removed just now is the part of SAP, tip of SAP?
So you can say the L4 root.
The bone you have removed? No, you cannot listen.
Yeah. It's the extra portion, you can see L4 root. Right? It's L4 root. It's frame 1. Okay. This is L4 root. Can you see? Proof. Proof. It's L4 root here. It's L4 root. Okay. Punch forward. 2 millimeter. 2. Okay. Okay. Bipolar. Almost. It's L4 here. Okay, punch forward. Wow. It's extra pressure. 3.
Проверьте, пожалуйста, микрофон, мы вас не слышим. Стас, проверь микрофон.
कहाँ L4 रूट यार? हमको L4 हेलो हेलो We cannot hear you, sir.
Стас, проверь микрофон. Батарейки на приемнике и передатчике.
रहा है उसको लेके देखिए.
Hello, can you hear me? Hello.
Да, мы вас слышим.
Hello.
We are hear you.
Can you hear me?
Hello, sir. Yes. We are hearing you.
Hello. Any question? Do we have?
Dr. Lim, thank you. I think there is no question. No, thank you, Dr. Lim. No questions.
Inside the problem. The patient has severe the narrowed space and the calcified ligament flavum, the severe adhesion, and to remove the bilateral decompression was it took a long time, and also the foraminotomy using contralateral approach was very difficult. But with one scalpel, we can do foraminotomy and bilateral decompression.
Okay, thank you, sir. Yes,
it's
it was
one of the strategy of the endoscope surgery.
Yes, it was.
So we can avoid the fusion surgery this patient.
Yes. It was a great surgery. Thank you, Dr. Lim.
Okay.
So the case finished. Thank you. We are inviting our guests to the dinner, and we'll meet with you, Dr. Lim, at the dinner. Thank you very much.
We can talk about.
We can discuss there.
In dinner time.
Yeah, thank you.
Thank you. See you at the dinner time. Thank you.
Yeah, thank you, sir. Dinner time.